welcome to the Sunway Medical Center, Sunway City Skin Symposium 2025 with the theme Redefining Skin Health, Science, Care and Excellence. This is a collaboration event with Beating Hearts and Docwity, and we are thrilled to have you with us today, physically and virtually. So this event, as we come together to raise awareness and provided valuable information about skincare. So before we dive into the day's activity, please make sure to register at our registration counter and pick up your complimentary goodie bag. So we also have a variety of exciting booths from Galderma, Eucerin, Medsense, Hypens, and Inon Pharma lining up for you outside. So again, good morning, ladies and gentlemen. My name is Shi, and I will be your MC for today. So before we begin our event today, please allow me to highlight to you on a few important items to ensure the smooth running of today's programs. So do set your phone to silent mode, and please be seated while we are expecting the arrival of our esteemed guests. Thank you, everyone. Before we start, a very good morning again and a warm welcome to Dr. Betty Tay, Consultant Cardiologist and CEO of Beating Hearts, Ms. Tan Mei Shin, Senior Director, Business Development and Corporate Communications, Sunway Medical Center, the management team of Sunway Medical Center, Sunway City. So again, welcome to Sunway City's Skin Symposium 2025 with the theme Redefining Skin Health, Science, Care and Excellence. So to kick off the event today, we'll first hear a welcome speech from Dr. Betty Tay, CEO of Beating Hearts and Consultant Cardiologist of Sunway Medical Center, Sunway City. Please welcome Dr. Betty Tay.
Here. Ladies and gentlemen, esteemed speakers, colleagues and friends, good morning and welcome to our Skin Symposium 2025. I am truly honored to be standing before you, as the CEO of Beating Hearts, in collaboration with Sunway and Docwity, to bring you some of the brightest minds in dermatology, plastic surgery, and aesthetic and healthcare. At Beating Hearts, we are dedicated to 4 pillars, key pillars: educate, empower, enable, and excel. Now, these are not just words, but it represents our commitment and our mission to support you, all professional, healthcare professionals, doctors, be it nurses or pharmacists, all healthcare professionals, in advancing your medical education. At Beating Hearts, we'll think that when we educate, education is the foundation of excellence. We will then expect you to improve on your patient health care. Today, we are privileged to have leading experts who will share their insights, their experience, and their knowledge in skin diseases, burns, plastic surgery, aesthetic, and with empowerment with education comes empowerment, because education allows us confidence. Our goal is to equip you with the latest advancement to provide the best possible care to your patients. Enable, even though we educate, it is important that we practice what we learn. So it is important that we elevate the healthcare standards and improve patients' outcome. Excellence. So we excel when we educate, we empower, and we enable. And excellence is not a journey, it is not a destination. It is a continuous journey. And with these 4 key pillars, we can then translate it to our clinical practice and use it in our daily practice. Today's event is particularly special because it coincides with Chinese New Year. It is a time for renewal, growth, and a new beginning. So With the conjunction of Chinese New Year, we like to celebrate this occasion with a lion dance and a yisang toasting during lunch. We hope that this will symbolize future prosperity, unity, and success in the coming years. As we embark on today's sessions, I encourage you not just to listen, but to question, to challenge, and to engage our speakers. Learning is most powerful when it is shared. And together, by sharing this, we can push the boundaries of healthcare. Thank you.
Thank you so much, Dr. Betty. So next, we would like to invite Ms. Tan Mei Shin, Senior Director, Business Development and Corporate Communications, Sunway Medical Center, Sunway City, to give her opening remark.
A very good morning to all. Dr. Betty, our consultant cardiologist, CEO and also founders of Beating Heart, esteemed consultants and speakers, GPs, specialists, allied health professionals, nurses, organizing committee, ladies and gentlemen. On behalf of the organizing committee, we are pleased to host the first Summit Skin Symposium, Redefining Skin Health, Science, Care and Excellence at Sunway Medical Center, Sunway City, the largest private quaternary hospitals in Malaysia, in collaborations with Beating Heart. Symposiums like this allow us to explore and share valuable insights, as well as foster collaborations on issues surrounding skin cares, dermatological diseases, innovation in skin health, new treatments, and discuss challenges in both clinical practice and patient care. Our skin centers is among our 28 centers of excellence at Sunway Medical Centers, equipped with the state-of-art equipment and expertise. We have the highest numbers of dermatologists in Malaysia. Our 6 dermatologists and skin specialists collaborate closely with our multidisciplinary teams and are ready to provide the best skin health treatments for our patients. Ladies and gentlemen, 2025 started strong, with SMC recently honored among the top private hospitals across Asia in orthopedics and ophthalmology under the Asia Top Private Hospitals 2025 ranking by Newsweek, where we secure the 2nd and 3rd ranking for cataract and refractive eye surgery, respectively, in Asia, 6th for both hip surgery and hip replacement, and knee surgery and knee replacement, and 10th ranking for shoulder surgery. While in Malaysia, we are recognized as the top private hospitals for the top 4 key procedures, which is including the knee surgery and knee replacement, shoulder surgery, cataract surgery, and refractive eye surgery. These recognitions further cements our steadfast commitment to healthcare excellence and the positions as one of the leading private hospitals in the regions. 2024, too, was a milestone year for Sunway Medical Center, marked by several significant achievements. We proudly celebrated our 25th anniversary last year, November 2024. We were ranked among the top 250 hospitals globally in the Newsweek World Best Hospital 2024 list. And this year, the 2025 list will be announced on the 26th of February this year. Apart from this, we also became the first private hospitals in the country to acquire 3 prestigious hospital-wide accreditations, which include the Joint Commission's International's Gold Seal of Approval from USA, the Australian Councils on Healthcare Standards, as well as the Malaysian Society for Quality in Health. The Asia Top Private Hospital 2025 is just the beginning, and where we're anticipating to achieve more accolades and hit more milestones this year. Going back to today's symposiums, we will feature an engaging agenda that includes the expert-led talk on skin disease in systematic illnesses, plastic surgery perspective on skin, post-menopause skin rejuvenation, psoriasis and eczema, I'm confident that the insight shared today will provide invaluable takeaway to help us to serve our patients better. Allow me to convey my appreciations to everyone, the experts who will be speaking today, as well as all of you, our participants, for taking your time to attend today's symposiums. We deeply appreciate your ongoing support. A special thank you to Dr. Betty for your continued support, as well as the collaborations in organizing these symposiums. Before I conclude, I would like to take this opportunity to wish everyone a happy Chinese New Year, and to those who are celebrating Kong Si Fa Chai. May this year bring you joy, good health, and continued success. Thank you.
Thank you so much, Ms. Tan Mei Shin, Senior Director of Business Development, Corporate Communications, Sunway Medical Center, Sunway City. So before we proceed to the exciting program, can we have our consultants and also our top management of Sunway Medical Center to have a group photo? I will invite Dr. Betty, Ms. Tan Mei Shin, Dr. Jeffrey, Dr. Lee Yin Yin. Any other consultant outside? Do we have any consultant outside? All right. Can we have a quick group photo, please? Please welcome. All right. Can we have our photographer ready? All right, can we have one with the participants? You may sit at your designated chairs, and our photographer will be taking from the stage. All right, my dear participant, please show us your biggest smile. Please take off your mask for a while. Look at the stage. Whoever yang dekat belakang tu can bangun. Okay. Smile. Look at the camera. Alright. Perfect shot. Alright, so I forgot to wish, thank you so much consultants and also participants. I forgot to wish Happy Chinese New Year, Kong Si Fa Chai, and welcome to a exciting programs of the day. I mean, despite the talks, we have a performance, line dance performance. So yeah, again, we now present to you the lion dance performance. All right, we would like to invite Ms. Tan Mei Shin and Dr. Betty Teh to be on the stage, and to our consultant as well, Dr. Jeffrey, Dr. Lee, for a group photo with the lion dance. Hong Hua Da.
Everyone stand up to have a picture, one group photo together. Yeah, for all the guests.
Can we have those at the back to be, but stand up and to take a group photo? You guys want to stand up for a group photo with the cute lions? Okay, photographer, please. Everyone, stand up, please. Oh my God, for your photos. All right, everyone ready? Smile. All right, thank you so much. What an awesome performance, my dad. awesome lion dance performance. Yay! Voila, honga, henga. All right. So may this year bring you good health, happiness, and an abundance of success. So enough of the lion dance. Let's proceed to our first session for today, topic of the day. So now I would like to invite Dr. Lee Yen Yen, consultant dermatologist, Sunway Medical Center. We'll talk about the topic skin disease in systematic illnesses. Please welcome Dr. Lee Yen Yen.
Testing. Yes, okay. Good morning, ladies and gentlemen. I would like to wish everyone a happy Chinese New Year and Gong Hei Fa Chai to those who are celebrating. Sorry for the voices, and I can assure you it was not the karaoke or the CNY cookies. Okay, so today I would like to share with you on the skin manifestation of systemic diseases. So we do know that skin is the largest organ in our body, and it is oftentimes known as the organ, the window that is a reflection of general health. At the same time, it also mirrors what is happening in our body internally. So we do know that most patients with a rash do not have a systemic illness, but many systemic diseases do come with a skin manifestation at some form of time. So there is, at this moment or until now, no useful classification that can associate skin manifestation with certain group of diseases, but we do go by certain categories such as skin manifestations in internal malignancy or organ system involvement such as endocrine system, cardiovascular, respiratory and whatnot. And also we can categorize skin manifestations associated with pathogenic mechanisms such as autoimmune condition or connective tissue disease, or by their characteristic pattern such as reaction pattern and for example erythema nodosum or erythema multiforme, in which I will go further on later. So from medical student days, we have always been drummed that we need to have a keen eye to look out for skin manifestation associated with malignancy. So there are a few important but not very common skin manifestations that we have always been taught, and I would just like to highlight a few today. So it can be acanthosis nigricans, adult dermatomyositis, acquired ichthyosis, or erythema gyratorum repens. So do we still remember the association with malignancy? No worries. So I will just mention briefly acanthosis nigricans. If we see that and if we suspect there's a malignancy, we need to look out for adenocarcinoma of stomach, lungs, pancreas, colon, and ovary. And for adult dermatomyositis, for us in dermatology department, if we diagnose a patient with adult dermatomyositis, we always need to refer them to our ENT surgeon to rule out nasopharyngeal carcinoma. As for acquired ichthyosis, oftentimes if we suspect that there is a malignant component to it, then we need to rule out Hodgkin's lymphoma, myeloma, or solid organ tumors. For erythema gyratorum repens, the most commonly associated malignancy is still the lung cancer, followed by less common breast, esophageal, or tongue malignancy. So let's go through acanthosis nigricans, and we can see that the characteristic pattern of this rash is velvety papillomatous overgrowth of the epidermis, and oftentimes you can see darkening or thickening of the skin. So in this photo, you can see that there's a hyperpigmentation over the posterior neck. They are also often seen in other areas such as the axilla or inframammary region. So even though acanthosis nigricans, we said that yes, we have to always think of malignancy, but more commonly it is associated with other conditions such as obesity, diabetes, or insulin resistance, and less commonly internal malignancy. So you can see in this photo that this is a lady with a very thickened or hyperpigmented skin and exaggerated regions over the neck and also periorbital region. And this is a paraneoplastic features, and she has actually metastatic tumor. So again, more photos. This is not so prominent thickening, but hyperpigmentation is there. This is hyperpigmentation associated with varying sizes of skin tags over the axillary region. And again, this is hyperpigmentation and also thickening of the skin on the dorsum hands. So always think of adeno-CA of stomach, lungs, pancreas, colon. Next would be the adult dermatomyositis. It is not very common, and the incidence is less than 6 per 100,000 population. Generally, the peak age is 50s or 60s, but if we see a patient with adult onset dermatomyositis, we need to always think of malignancy, because it is not like the juvenile dermatomyositis whereby it can be immune mediated. So up to 25% of the affected individuals with adult dermatomyositis come with adeno-CA. So we do also again need to remember that a few classical signs that oftentimes is associated with dermatomyositis, such as a periorbital heliotrope rash, whereby it is a bluish, purplish discoloration, oftentimes affect the upper eyelids of the eye. So where does this term heliotrope come from? It is actually from these clusters of flowers, and the flowers are natives of South America, and these are actually almond-scented flowers, and in the language of flowers, they actually indicate devotion and eternal love. But of course, it is not so in adult dermatomyositis. So, and then shawl sign. Shawl sign is also oftentimes associated with adult dermatomyositis. And you can see that the reason why it is called shawl is because of the distribution in the shawl area, the back, the shoulders, the chest, and the neck region. And over here, you can see redness or erythema of the skin. But over time, they can progress to become poikilodermatous. So, and poikilodermatous basically means there's a mixture of hypopigmentation of the skin together with some telangiectasia and skin atrophy. So if we examine the patient closely, looking at other body areas, we can again see all these papules, plaques over the dorsum, small joints of the hands. And looking at the nail fold, you can actually see that there's some cuticle which are ragged, and also nail fold or periangle telangiectasia. So more photos, these patients again with periorbital puffiness and edema, and there's erythema over the forehead, the ears, and also the neck are affected as well. And this is again a better photos with this bluish, purplish discoloration of the upper eyelid. And over here, shawl sign, and here you can see hypopigmentation with some skin atrophy, the poikilodermatous changes. So next would be the acquired ichthyosis. So they may or may not be associated with malignancy, but if it is associated with malignancy, we need to always rule out Hodgkin's disease, multiple myeloma, or cutaneous T-cell lymphoma. Other systemic disorders that can present with acquired ichthyosis are such as hypothyroidism, even leprosy. And certain medications also can lead to adult onset ichthyosis, such as cholesterol lowering medications, allopurinol, or cancer targeted therapy. So they look very dry. You can see fish scales appearance and very scaly with some hyperpigmentation. Essentially, they do look a lot like ichthyosis vulgaris, but this is adult onset. And erythema gyratum repens. So this, you can see a paraneoplastic rash, and they can present as these erythematous concentric bands over the trunk. Yeah, you can see this pattern. Some may actually mistaken this for fungal infection because of this pattern. And there is a strong association with malignancy in about 80% of patients. If we diagnose as erythema gyratum repens, we need to look hard for malignancy, oftentimes in Caucasian men. And association with lung cancer is quite high, about a third to 50% of the patient. So next we will go through the skin and systemic disorder, and due to the time constraint, I will just concentrate on skin and metabolic diseases. So going to adrenal diseases such as Cushing's, Addison's, dyslipidemia, diabetes, and hyper and hypothyroidism. So Cushing syndrome, as we all know, is due to prolonged exposure to high circulating plasma cortisol level. And the causes of Cushing syndrome can be quite a number, mainly adrenal cortical hyperplasia due to pituitary overproduction of ACTH. It can be due to benign or malignant adrenal tumors, ectopic ACTH, or exogenous steroid administration. So I think this last category is what we do see very often, patients presenting to our clinic with Cushingoid features, and when you take further history from patients, they would have at some point taken some traditional complementary medication either for pains or other conditions. So in this Cushing syndrome, there are a few features that we often look out for or we often observe in our patients, such as rounded faces or moon face, buffalo hump, supraclavicular fat pad, and patients do bruise quite easily, so they may present with a purpura or hematoma on the limbs and other body parts, skin atrophy, telangiectasia, and also striae. So you can see this is actually very significant striae over the abdomen, arms, inner arms, and this is moon face or rounded face. So more of the other features, so they can also present with acne, breakouts, facial erythema, and again more moon face, and this is also moon face with supraclavicular fat pad. So when you see these patients, we need to always think that, does this patient have Cushing's, and could it be exogenous or endogenous, and work out from there. So now this is the other extreme of this adrenal condition, whereby they have primary adrenal insufficiency in Addison's disease. And this condition is associated with severe or total deficiency hormone production by the adrenal cortex. So we do know that the two important hormones produced by adrenal cortex are the cortisol and aldosterons. So up till the mid-20th century, the cause of Addison's disease are still tuberculosis, but with the early intervention or detection and less cases of tuberculosis now, we need to always also think of autoimmune disorder or chronic infections or cancers associated cause of Addison's disease. And patients can present with Addison's disease with sort of severe lethargy or salt craving, and also extreme weight loss. So what clinical presentation or skin manifestation do patients with Addison's disease have? So they do have generalized hyperpigmentation, and the areas which we often see are the exposed area, body folds, or creases. So you can see that this is very prominent hyperpigmentation over the creases of the hands and fingers. And other areas can also be affected, such as the armpit, genital, and the gum. So this you can see the dorsal aspect of the feet, the hands, and hyperpigmentation over the gum, the lips, and also the tongue. So what do we see here? So you can see this hyperpigmentation or longitudinal melanonychia over the nail, and longitudinal melanonychia can be the first or the only skin manifestation in patients with Addison's disease. So what about next? Skin and dyslipidemia. So the common skin association with this abnormality are xanthomas. Thanks. So they can be associated with either primary or secondary dyslipidemia. So in primary dyslipidemia, we have to look out for this, either they can be having hypercholesteremia or hypertriglyceridemia or combined dyslipidemia. Whereas secondary dyslipidemia generally is due to metabolic causes such as obesity, diabetes, insulin resistance, liver condition, nephrotic syndrome, or due to intake of medications such as estrogen, tamoxifen, or oral retinoids for the management of acne. So xanthomas, they are due to accumulation of fat in macrophages in the skin. And there are many types of xanthomas that we see clinically, such as xanthelasma, tendon xanthoma, tuberous xanthoma, eruptive xanthoma, plain or palmar xanthoma. So you can see these are the xanthelasma, tendon xanthoma over the dorsum hand, and also the tendons here, and these are other xanthomas. So xanthelasma is very commonly seen, and in fact, this is the most common form of xanthoma. It is usually at the medial canthus of the upper eyelid, but it can happen any areas at the periorbital region, the lateral eyelid, or the superior or inferior border of the eye. So they usually start off as a small little yellowish tiny bump that people don't often pay attention to, but gradually over years or months they can actually get bigger, and it can be cosmetically concerning to patients. So oftentimes they come and patients want them to be removed for cosmetic reason. So treatment can be either, if they do have hyperlipidemia, definitely we will suggest to put them on these lipid lowering agents. But the patients can also present with a normal cholesterol level, normal triglyceride level, and if they would want treatment for this condition, they can opt for laser treatment, curate, or even trichloroacetic acid. So eruptive xanthoma is associated with hypertriglyceridemia, diabetes, obesity, hyperthyroidism, or chronic kidney condition. So you can see that these are very tiny yellowish papules with erythematous rim around them, and they are usually quite sudden onset, non-tender, non-pruritic. Oftentimes they present on the extensor surface such as the knees, the elbows, buttock, or oral mucosa. And they may also demonstrate capitalization, which is eruption of lesions over the areas of trauma. So next will be skin and diabetes. We do see a lot of skin and diabetic patients in our clinical setting, and about a third of patients with diabetes do present with some form of skin condition. So common skin disorders associated with diabetes are such as infection. They can be bacterial, fungal, or even parasitic infection. Many of them do have a diabetic dermopathy at, if the diabetes has been quite long-standing, or they can present with diabetic bullae, even though it's not so commonly seen. So you can see this is a tense blister over the medial aspect of the foot in patients with diabetic bullae, and this is yellowish honey-crusted lesions over the chin, which is impetigo, and these are some changes which is suggestive of diabetic dermopathy. So let's go to diabetic dermopathy first. Commonest skin issue in diabetic patient, and it is occurring about a third of patients with diabetes. They tend to occur in those who has long-standing diabetes, more than 10 years or so, and they are characterized by reddish or brownish, oval or roundish, slightly scaly patches on the shin. So oftentimes it's on the shin, and especially after trauma. So the exact cause or mechanism of this diabetic dermopathy is not known, but they are often associated with a diabetes patient who also has neuropathy or vascular complication such as retinopathy, neuropathy, or nephropathy. So how about diabetic bullae? They are also known as bullosis diabeticorum. So earlier on, I showed you a picture of bullae, and this is again another blisters, clear fluid inside over the foot. So blister eruption, they can happen spontaneously either on the feet or hands of patients with diabetes. It is not very common, but if it is present, then it is quite a distinct marker for diabetes. And it is more common in men. And as I mentioned earlier, usually in long-standing diabetic patients or with diabetic complications such as neuropathy. So diabetes and skin infection, oftentimes patients come to us with some form of infection and they do have coexisting diabetes, or they have not been diagnosed with diabetes, but due to the nature of the skin manifestation, we investigate them and diagnose them with diabetes from blood investigation. So they can be bacterial infection, forming abscesses, paronychia or cellitis, or fungal infection on the body folds or the nails. So you can see in this, paronychia, there's a pus collection at the nail fold. And this is a well demarcated erythema. And if you feel the skin, they do get some tenderness, it's warm and it's red. So this is a cellulitis, and this is an abscess. So more of this inframammary, they can have this dry, peeling, itchy skin. This is candidiasis. And on the nails, you can see that all the nails are quite dystrophic, and there's discoloration of the nails, onychomycosis, fungal infection of the nail. And how do I go back? Yeah, I think. Yes. Okay. Okay, so again, this is at the inguinal region. So you can see well demarcated erythema and axilla. So these body folds are common areas where patients develop fungal infection. Again, so you can see that these are erosion, and oftentimes tinea cruris can present with severe itch, and when patients scratch, they can get secondary trauma, and it may also lead to cellitis or infection. And these are the feet of patients with dry scaly skins. This is well demarcated erythema over the medial aspect of the foot, over the groin region, and they oftentimes also do have this maceration or white scaly patches over the toe web spaces. So if a patient comes to your clinic with cellitis of the leg, we always have to look at the interdigital web space, because oftentimes they do have fungal infection that predispose them to have cellulitis. So, and ultimately, some patients may have the gangrene due to diabetes, and due to the uncontrolled sugar level or hyperglycemia, it actually allows non-pathogenic organism to establish an infection in traumatized skin. And over time, they can actually become necrotic gangrenous and lead to all these changes. So treatment of choice would definitely be amputation to prevent sepsis and also infection that will ascend proximally to the other areas. Next will be skin and hyperthyroidism. So most patients with hyperthyroidism, they will not just go to your clinic and do a blood test and check for their thyroid condition, but they do oftentimes have manifestation or skin manifestations such as warm, moist skin. They do have reddish palms. They feel that they sweat more often than others, even in a cooler environment, or they have sort of acute or subacute hair loss, generalized itchy skin, or nail changes, and other changes in other body parts. So you can see this palmar erythema. So erythema over the palms areas and also the fingers. And over here, you can see that there's these changes which onycholysis, whereby there's separation of the nail plate from the nail bed, and there's opaque changes, discoloration of the nails. And this is a thinning of the hair over the scalp. And patient can also present with just urticaria. So if it is, urticaria that has been there for quite a while, rather than your 1 week acute onset urticaria, then we need to always think that could it be associated with thyroid disorder. So this is a more advanced stage of hyperthyroidism, whereby they present with thyroid acropathy. So you can see that there is clubbing of the fingers. There's a hypertrophy of the surrounding tissue due to glycoaminoglycans deposition. And oftentimes this happen in both the hands and they are quite symmetrical on both sides. So this is what we see in patients with Graves' disease and pre-tibial myxedema, whereby they have this reddish and oftentimes tender nodules or plaques over the shin. They can also happen on the calves and the feet. So how about skin and hypothyroidism? So this is the other extreme of the thyroid condition, whereby they can present with dry skin, they can have cold skin as well, and yellowish discoloration of the skin, myxedema, macroglossia, or loss of eyebrow and rough brittle hair. So you can see this is a normal palm. This is a patient with yellowish discoloration of the palm. And this is pre-tibial myxedema. So pre-tibial myxedema can happen in patients with Graves. They can also happen in patients with hypothyroidism. And this is basically dry, scaly skin in patients with hypothyroidism and macroglossia. So these are changes before and after the onset of the disease. These are all normal nails, and this is presence of onycholysis. Again, head full of hair, and then they have this diffuse hair loss. So skin manifestation together with pathogenic organism that I mentioned earlier, and it is a very big topic. So today I'll just mention briefly on lupus. So lupus erythematosus is a diverse autoimmune inflammatory disease and affects about 5 million population worldwide. So we do know that SLE can involve multiple organs such as the skin, the joint, the kidneys, and the clinical features of SLE is highly variable. So it is oftentimes known as a disease of mimicry. It can mimic any other condition, and we have to look hard and investigate thoroughly for SLE. So skin involvement is about 80% of LE patient, and generally they are more often in female as opposed to male, and in younger age group as well. So in lupus, they can present with acute cutaneous lupus, whereby patients have malar rash or butterfly rash over the cheeks and crossing the bridge of the nose. They can have photosensitive dermatosis over the extensor areas such as the face, the V of the neck, upper back, extensor arms. They can present with oral ulcers, hair loss, urticaria or urticarial vasculitis, livedo reticularis, erythema multiforme, and others. So in subacute cutaneous lupus, they can present with this papillosquamous, or we known as the psoriasiform rash, or they can also be polycyclic annular in pattern. So you can see all these are annular polycyclic rashes in the patients with subacute cutaneous lupus. And in chronic cutaneous lupus, the discoid lupus can either be localized or generalized. So you can see this at the preauricular region. So acute cutaneous LE, it also can be localized or generalized in, and it happened in 30% or to 50% of patients with lupus. So localized will be just classical malar rash that I showed you earlier, and generalized will be involving the photosensitive areas. And in this patient, you can see that there's erythema over both the cheeks, across the bridge of the nose, some on the forehead and over the chin, and classically they spare the nasolabial fold. As for this dorsum aspect of the hands, you can see that there are erythematous papules or plaques, but they also spare the knuckle as opposed to dermatomyositis where there's always knuckle involvement. So subacute cutaneous LE, usually they are widespread, but they do not cause scarring in the photosensitive areas. They may resemble psoriasis. So if patients do not have other symptoms and they came to the clinic with this kind of rash, you may actually think that they do have psoriasis. And it affects about 10% of lupus patients. Typically, they are symmetrical over the sun-exposed area, the upper trunk, or the upper back areas. So again, they look psoriasiform, and this one is more annular polycyclic erythema. So chronic cutaneous lupus affects about 25% of patients with lupus. They can either be localized in 80% of the case or generalized in 20% of the cases. So classic discoid lupus, they can present with this hyperpigmented or erythematous papules or plaques over the skin, and they can also present with all these scaly patches over the ear, the carpet tag sign, the face, and also this would be the end stage whereby a patient has lupus profundus and they heal by scarring, indentation because of that atrophy. So we have always been taught in our medical student days that there's this classification of SLE that we need to remember. So we have to, patient has to have 4 out of 11 criteria present for us to diagnose a patient with SLE. So this is a 1997 update. So in terms of skin, they can present with malar rash, we've seen that, discoid rash, photosensitivity, or oral ulcer. These are the other criteria. But since then, 2019, the European League of Anti-Rheumatism and American College of Rheumatology has come up with a newer guideline for the classification of SLE. So in this guideline, patients definitely need to have this anti-nuclear antibody positive. If they are absent, you do not classify as SLE. And again, they need to have a score of 10 and above. So there are a few criteria that they go by: constitutional symptoms, hematological, neuropsychiatric, mucocutaneous, serosal, musculoskeletal, renal, and also immunology domains. So for skin, it's mainly non-scarring alopecia, ulcers in the mouth, subacute cutaneous or DLE, and acute cutaneous LE. So these newer criteria, it has higher sensitivity and higher specificity. But again, a lot of times clinicians do go by both the criterias, and this is mainly more academic. So next, characteristic reaction pattern. There are so many characteristic reaction patterns on the skin, but I will highlight a few such as erythema multiforme, subcutaneous nodules, particularly erythema nodosum and vasculitis. So erythema multiforme, this is a immune-mediated. Typically, they are quite benign and they can involve the skin and mucous membrane. So characterized by target lesion, and they are oftentimes quite symmetrical, involving the acral region. So this erythema multiforme, they can just present as an isolated episode, or they can present with recurrent episodes whereby they get the lesions, they get better, and then come again, or it can be persistent. So if you look at the erythema multiforme, which is persistent or recurrent, then maybe we have to investigate further to look out for conditions such as herpes simplex, or even COVID, or whether the patient has taken certain medication that could have triggered this attack, or vaccination history. So you can see that these are very classical target lesions, and they have this concentric rings of color variation. The central will be central dusky area of epidermal necrosis. Sometimes there's a blister at the center, followed by this surrounding lighter edematous area and a peripheral erythematous margin. So you can see that they may also sometimes present with this lip involvement, such as oral erosions or oral ulcers. So next, erythema nodosum. We do see this patient in our practice not uncommonly. And erythema nodosum basically is panicleitis of the subcutaneous fat, and they present as red tender nodules. Oftentimes, if you run your hands across the shin areas, they will be complaining of pain, especially when you touch on those nodules. It is very common at the anterior shin, and more amongst the female as opposed to the male. So if we see a case of erythema nodosum, or these tender nodules, we have to think of a few important causes, such as infection. They can be viral or bacterial, primary tuberculosis, fungal or parasitic infection, drug intake such as OCP, or sarcoidosis and malignancy. But oftentimes they can just be idiopathic. So cutaneous vasculitis, again, a very big topic. They can be divided into small vessel vasculitis, medium vessels, or large vessel vasculitis. So the one that we often see are either idiopathic or Hannock-Schönlein purpura. So these are particular purpura, and they can sometimes also form blisters. I will just touch on Hannock-Schönlein purpura, in which we do see in our practice. So it is a leukocytoclastic or small vessel vasculitis, and oftentimes seen in children. But I do see quite a number of adult patients presenting with Hannock-Schönlein purpura. So in a year, probably there are about 5 to 10 cases of Hannock-Schönlein purpura that I see amongst the adult patients. And it is due to inflammation of the small blood vessels on the skin and other tissues. So patient can present with just skin manifestation, or they can have a tetrad of signs and symptoms such as a vasculitic rash. Generally will be on the lower limbs, from the lower leg to the thighs to the buttock areas. And they may also present with arthritis together with the skin changes or abdominal pain, whereby they would think that it is more like a gastritis or kidney impairment. If we do urine test, they may have proteinuria or hematuria. So fortunately, most cases of HSP resolve without any long-term complication. So oftentimes we get a history that patient have an upper respiratory tract infection prior to the onset of rash. And if we want to investigate further, we can do a throat swab, which is going to show beta hemolytic streptococci. And if you do a blood test for ASOT, it will be a positive result. And for patients, if we are still in doubt whether is it HSP, we can perform a skin biopsy and sending out for immunofluorescence study, which it will show IgA deposit in small vessels. So I think these are further changes. All right, it can affect the lower limbs. You can see these are dusky central surrounding erythema. It can also affect the plantar surface of the leg. So I think we are done for now. And there are a few take-home messages that I would like to share, such as clinical dermatology is a very visual specialty. So we need to look, and we need to look hard and thoroughly at each and every rash that is present in a patient's body and examine the whole body. Of course, we locate the primary lesions, the main areas that the patient complain of, but we have to look at other areas as well and look out for the configuration and distribution of the rash. So with that, we ask appropriate questions so that we can classify the disorder, come up with a provisional diagnosis, and also list out the differential diagnosis based on the association. And if you are still in doubt, of course, carry out some laboratory tests or imaging that may help us to strengthen our diagnosis. Laboratory tests, we can send out for blood tests or send out for culture. If we suspect there's some infection, chronic infection, we can send out for culture, looking for tuberculosis or chronic fungal infection. And we send skin for biopsy to look at changes, not only on the surface, but if we do a biopsy, we can look at different layers of the skin, the epidermis, the dermis, and the fat layer. And if we want to define, the area of certain lesions, we can do ultrasound or X-ray, and then only treat. Because if skin condition that is not urgently needing treatment, we have time to go through all this slowly before we start the treatment. With that, I thank you for your attention.
All right, thank you so much, Dr. Lee Yin Yin. Now we open the floor for questions, and we have our volunteer here to pass you the mic. Please, state your name and also from which clinic. We also open the questions. Sorry. We also open the questions to our online participant. Please throw your questions in our chat box, and our consultant will answer for you. We also have the QR code in case you guys are malu to ask the question directly to Dr.
How do I see the QR code? Hi, good morning. Okay, we'll take questions. I think dermatology is one one specialty where observation is extremely important. Okay, no other specialty has that value where your eye is extremely important in making the diagnosis. How do we train the eyes? That's my first question. How do we train the eyes as the patient walks in to make the exact diagnosis even before he sits down?
I think the main thing is you need to have the knowledge. So if we always say that your eyes cannot see what you do not know. But if you know that, the association, then the eye can pick it up more easily.
Yeah, I think it's a matter of practice and a lot of experience. And that's why we have this symposium to share the experience of Dr. Lee. So there is a question. Can we use vitamin E capsule for face? Is that safe?
Vitamin E capsule as in orally or topically?
I think it must be orally. And I don't know whether this is related to your talk, but yeah, it's a question here.
Vitamin E, there's no definitive sort of value that we can derive from this for skin benefit. But topical vitamin E has been found to be effective in patients, in some patients for dry skin, or they claim to have some brightening effect. So oral vitamin E, I don't think that there's a very strong supportive evidence to show that they are good for face or anywhere on the skin.
I think this is a very good clinical question, with nail changes often leading to multiple differential diagnoses. What are the best approaches to start when looking at the nail lesions? I think this is a clinician.
Okay, I think in most patients with nail changes, they do not only have nail changes, but oftentimes they do have other skin changes. And again, in skin or any other field of medicine, we need to get the history, and we need to know the onset, and then is it associated with other abnormalities, and whether there's any family history, there's any trauma, there's any procedures, any manicure, pedicures that they have performed, and then only narrow down our differential diagnosis.
Again, it's back to experience.
Any questions from the floor?
Any
Doctors?
questions? Yes.
Any
please.
questions from the floor to Dr. Lee? Questions? Doctor,
And it's
questions?
really getting crowded behind. You can actually sit in
Yep.
front. There are 2 empty tables.
Any questions, Doctor? For Dr. Lee? Doctor, any questions? Any questions from the floor?
Okay, we go on first.
Yep.
With so many dermatological conditions, how do we categorize and differentiate lesions with similar morphology?
As I mentioned earlier, there's no useful sort of classification associating skin with any diseases, but of course we can go by category. So again, if morphologically they look similar, we can actually get more information by getting the history. So it's just like in a patient with earlier on psoriasis, or is it subacute cutaneous lupus. So one is over time whether there will be more other organs manifestations that can lead us to more information. Or the other thing is we can perform a skin biopsy. So oftentimes skin biopsy will be able to give us more information because they are looking at the skin in deeper areas. So our pathologists will be very helpful in that sense.
Okay, there are a lot of questions coming in online because we have over 500 people online. So I hope you don't mind. Where were we? Okay, does Linovera help with eczema? So Linovera, I'm not sure what it is, but we do have a session on eczema later. So I think maybe we can take that question. How do we treat diabetic dermopathy on top of the control of the diabetes? As patients always complain regarding skin appearance. True, they don't complain about anything else. when it's diabetic, but they will want to look good?
Unfortunately, there's no specific treatment that helps with diabetic dermopathy, and oftentimes it is mainly managing the diabetes and yeah.
Okay. Now, this GP asks, what are the life-threatening dermatological findings that we as GP cannot miss? That's a very good question, because it goes to the referral, which is urgent, to the ER.
Yeah, I think the main this emergency in dermatology is toxic epidermal necrolysis, TEN, and patient oftentimes present to the GP practice with sore throat, oral ulcers, or a little bit of skin rashes. So we always need to make sure that we get a good drug history to see whether there's any medication intake or any symptoms to suggest that the patient is going towards the severe acute generalized drug eruption. So if we suspect, then generally an immediate referral to the dermatologist would be appropriate.
Okay.
Oftentimes they may present with a sore throat, and they can easily be missed as having an upper respiratory tract infection.
And in this disease, how rapid do they turn bad?
They can turn bad very rapidly. So we always have to get a history whether they have any new medication intake, and whether they have any comorbidities. Because if the patient are elderly, have multiple comorbidities, they do progress and deteriorate in a very short period of time.
Okay, a doctor asks, for the first presentation of purpuric rash, without any other significant finding, is it necessary to take a skin biopsy and send for immunofluorescence, or just give a TCA to review it on a later date?
I don't think we need to biopsy patients, each and every patients with purpura, and we should actually observe and see whether there's a worsening, because if patient just present with an isolated purpura, it could be due to trauma, it can be due to other condition. So it will be good if we can advise patient to be very observant of the changes, and if it is worsening rapidly, they should go back to see the doctor early.
Okay. A GP asks, what are the common initial investigations that can be done by a GP or in a GP setting, especially for autoimmune skin diseases that they suspect?
Okay, very good questions. So I think in a GP setting, a lot of blood investigation can be done. So usually patients will bring with them actually a full report. You can include full blood count, renal, liver functions, and you can also do autoimmune screening, sending out for anti-nuclear antibody, C3, C4, rheumatoid factor, and or if some of the tests turn out to be positive, you can also order for ENA. And with this investigation, in fact, when they are ready, you can see either dermatologists or rheumatologists. We have a rheumatologist here in our crowd. And because if we do a blood test in our clinical setting, it generally takes about 3 to 5 days or even a week for the result to come back. So it will actually be quite helpful if the patient comes to our clinic with the report, and it can accelerate our management plan.
Okay, Dr. Yu asks, eczematous lesions are mimickers of different cutaneous or systemic condition. In primary care, we may misdiagnose and treat them as eczema. Is there any advice for us so that we don't miss out more sinister conditions?
Okay, so oftentimes patients can present with itchy, scaly rash, and we do diagnose them with eczema. But if the eczema does not respond well to treatment, it is worsening, then we need to think and re-evaluate to see if our diagnosis is correct.
Okay, there are many questions. Are there any from the floor? Okay, why some kids have white spots on their nails? Is there a common feature? I've never come across that.
Oftentimes, white spots on the nail can be traumatic. Yeah, so they knock on things and they develop these white spots. So they are actually quite benign. I cannot say that for most cases, but that is one of the common causes of obesity on the nail, tiny white spots.
But then it's understandable because kids always get
Yes.
themselves injured for some reason or the other. Okay, would azelaic acid be good for inflammatory lesion like acne?
Yes.
Can you just explain to us what's azelaic acid?
Azelaic acid
Explain
is
to
actually
me actually.
it's actually one of the topical treatment modality for acne, and it is helpful together. You can use it with adapalene or benzoyl peroxide for the management of acne. So azelaic acid, generally the brand name is Skinoran, and it is not only helpful for acne, active acne treatment, but it does have some lightening effect for acne pigmentation as well.
Okay, Dr. Sada asks, what can we do if patient develops scaly lesions all over the skin, like all? It's a very generalized question,
Yeah,
sorry.
it does
I-
sound very generalized.
Yeah,
So
so-
again, we need to come up with our provisional diagnosis and list out some differential and work on that.
Okay, how do we treat chronic tinea corporis despite oral and topical antifungal that has been given?
All right. I do see many patients with very recalcitrant fungal infection. And a lot of times, the reason why they are partially so recalcitrant is also because patient would have been buying medication from pharmacy off the shelf, thinking that they have some form of eczema, and they have received steroid treatment. So if the patient has a fungal infection and they have been given topical steroid or oral steroid as part of the management for the itch control, then generally it will take a long time for them to respond to oral and topical antifungal therapy. So always try our best not to use steroid if we have a suspicion that it is a fungal infection. Give them antihistamines for the itch and also topical anti-itch treatments such as clotamethone cream. Avoid steroid as much as you can.
Okay, I'd like to ask a question myself. How safe is topical steroid in the use of, for example, eczema?
Okay, I always tell patients that steroid is a double-edged sword. It is a very effective, very helpful treatment for skin conditions, but of course it does come with adverse effect. So if they are used appropriately in the, especially topical steroid, the correct potency for the appropriate area, then they are okay. But if they are used for prolonged period of time without any supervision from doctors, and they can actually cause a lot of skin changes or adverse reactions such as thinning of the skin, striae, and which was what you saw earlier on, and in fact, patients can develop acne secondary to topical steroid application and many other complications.
Okay, last question. Is the use of steroidal preparation safe for pregnancy?
Steroid, in fact, is one of the safest option for this eczema in patients who are pregnant. So they are used in this pregnancy most often rather than other stronger treatment.
Okay, some of the questions are not related to this, to this topic, and which we will discuss, for example, eczema, psoriasis, and squamous cell carcinoma. And if is there any questions from the floor? If not, we'll end the Q&A session. No? Okay. Thank you very much, Ying.
Thank you.
And
Thank
I would
you.
like to remind you to please silence your phone. Please silence your phone. Don't put it on speakerphone. And There are tables in the front. Please do come forward. And I pass the mic back to Shi.
Thank you so much, Dr. Lee Yin Yin, for her first topic of the day. There's slightly changes to our agenda for today. So before our coffee break session, can we start with our next speaker? All right. So our second talk will be by Dr. Margaret Liu, with a topic, Skin, a Plastic Surgeon's Perspective. Do we have Dr. Margaret? Are you ready? All right, Dr. Margaret Liu, a consultant plastic and reconstructive surgeon at Sunway Medical Center, and she will share her thoughts about a skin plastic surgeon's perspective, burns. So, Dr. Margaret, the floor is yours.
I'm sorry, I'm a little bit late. I'm on call. Where is it? Slideshow. Why doesn't it go?
All right, please save your questions for Dr. Margaret because after Dr. Margaret, we have Dr. Jeffrey and we have a panel discussion after this, yeah?
I'm supposed to stand on there. Are you sure? I'll take my weight now. You sure? Okay. Hi. Good morning, everyone. I'm Dr. Margaret. Me and my colleague, Dr. Jeffrey, are going to give a very short talk on the plastic surgeon's perspective on skin. So we have split it up because we didn't want to overlap with one another. So I'm going to talk about burns and he's going to talk about skin cancers, although we both do both. I just want to first thank Dr. Betty for organizing this symposium and to thank her for inviting us and to thank you all for coming on this 12th day of Chinese New Year. Okay, so burns actually is very badly managed, as far as I can tell. Okay, I have nothing to declare. I am not linked to any dressing company, right? So this is the outline of my talk. I usually start with understanding of burns, but it's very dry, so I'll move directly on to management. And if you have time, then you can ask me about why we do what we do. Okay, so the CDC estimates that about nearly 400,000 people get burnt every year. Estimates are about 1% here in Malaysia, okay? And the most common people who are affected are children. And whenever children are burnt, it's always an adult's fault. It's because they were careless, okay? And most of the burns happen at home, and most of them are scalds, okay? So the first thing you need to know is that we need to do first aid. It's the most important thing. Unfortunately, most people panic and then they rush out of the house and go to the nearest GP, and it takes at least 20 minutes or half an hour to get there, by which time, that time when they could have been cooling the burn is over. Okay, so the whole idea is that actually the country needs to move on to educating the public and talking about how to prevent burns in the first place. So these are some of the posters that are up from other countries about how to prevent burns and what to do immediately after a burn. And these are I've taken from other countries where you need to cool and then you need to call for help and then you need to cover and protect it. And the first thing you need to do is really to cool the burn, because that will stop it from becoming deeper. Okay, I think people know this in Australia, where you just stop, drop, and roll instead of running. And then the oxygen lights up the flames and it becomes bigger and deeper. Okay, so the first step is to stop the cooling process, and the best way to do it is to use running water. We are very lucky in this country. temperature of the water coming out of our taps usually is the perfect temperature. It's not too cold, and it's just the right temperature for cooling a burn. Unfortunately, our pipes sometimes run through an outside pipe, which is also you have to check the temperature before you put your hand under. Okay, so you let the warm bit go first, and then you put your hand under and cool. If, let's say, it's a hand or something that can be dunked, you can put a bucket and dunk your foot or your hand in it, and the process of getting to your health provider. Okay, you shouldn't use ice, because ice will then cause the other end of a burn, which is a frostbite. Okay, so there are other things that can be used. There's this thing called Illuminate, there's Burn Shield, and there's Burn Aid. I think some first aid kits have them. I think some firemen carry them. Okay, so whatever you can think of to cool a burn, don't please use things like toothpaste, honey, butter, lemon. Okay, I have seen all kinds of things put on burns. I've seen people put salt. I've seen people put, like, ketchup. I mean, you're not marinating chicken here. You are trying to cool a burn. Okay, so all these are the wrong things to put on. Okay, so as you all know, I assume that you all have done some ATLS. That's the most important thing. So airway, breathing, make sure there's no inhalational injury. Okay, so that one you really have to come to a hospital. Okay, especially if there's a history of burn in a closed environment. Then circulation, and you need to assess the burn. Remove all clothing so that you don't miss any place that might have, either spill a bit of hot water or spill a bit of acid or whatever. But when you open them up, our A&E is very cold. You need to stop them becoming hypothermic as well. So you need to use blanket and cover here and there. For the big burns, you need IV access. And for most people, we calculate our resuscitation and our medications using their correct weight. Okay, so you need to weigh the patient. It's more important in children as well. Okay. And then you need to, of course, examine and remove all jewelry. Patients are going to swell up. Their face is going to become 3 times what it normally is, and everything is going to swell. All the rings, all the earrings, wherever la, eyebrow la, tongue la, nose la, everywhere that you can think of, remove them. Okay. I think very weak, is it? Didn't eat breakfast. Okay, so then there's escharotomy if for full thickness burns, and then there's fasciotomy if you have crush injury. Sorry, and then and if you have a burn, it is very, very painful. Any of you ever had a burn? Put up your hand. Anybody? Yeah. Okay, so you know how painful it is, and really don't mess around with paracetamol or aspirin. IV morphine, okay? That's the only thing that will take the pain away and to cool it, all right? So then you need to give your tetanus prophylaxis and then your ulcer prophylaxis. And usually for big burns, you need an NG tube because their stomach goes into stasis. But we usually do not start antibiotics. There was a study done after the Bali bombing, and half the patients were flown to Singapore and some of them back to Australia and some of them stayed on in Indonesia. They did a study, the Australians, and they swabbed every one of the patients coming back. And most of them, almost all of them, grew nothing. So whenever you have a burn, usually they are sterile. After a few days, then they get, colonized or infected or whatever. Okay, so do not, please, I beg you, do not start antibiotics. Okay. For blisters, it depends. Some of them, if they are breaking already, you should just get rid of it. It's dead skin there. But some of it is like a protective covering. So it depends on where the blister is and whether you think it's going to burst and get in the way and cause a problem. Okay. Next is the wound care, which I think is where you guys mostly do your own thing. For temporary wound care, if you're going to send them on to someone else, and if you're not used to dealing with burns, then I really suggest you do that. Okay, so then don't use expensive Gelanet or something like that. Just use cling film. It's easy, it's cheap, the inside of it is sterile. You just wrap it up. The moment you wrap it up, it takes the pain away, okay? And then you can cover it with a crib bandage or, I don't know, a blanket or a towel or something, and then just hold it with a micropore and send them on. Okay, it's cheap. And then all we have to do is open the outer layer and just look at it through the cling film. And then we don't have to open, don't have to cause them extra pain. Okay. And then after that, if you're going to be treating it, then you do the definitive dressings. And there are lots of different types. There's the non-adherent dressings, adherent dressings, and I'm not going to go through every single one of them. Okay. I like Mepitel for little kids because it doesn't stick. Okay. But I've also used like Tegaderm on myself where I had an iron burn and I kept it for 10 days and I was able to work, to scrub, to wash every day. And then at the end of 10 days, I can take it off and it's all healed. So it depends on the burn, how deep it is, where it is, and whether you did any first aid to it and the management thereafter. So there are things like hydrocolloids, okay, which is like Duoderm. Dr. Jeffrey loves them. And then there's alginates, which is Caltostat, which is what I use for donor sites. And also Aquacel hydrofiber dressings. There are other modern dressings. I used to love Aquacel AG Burn. I could leave it for 2 weeks, but the little thread on the inside sometimes stick, and then when you pull it off, it starts to bleed. So I've moved on to Polymem. I can do this dressing. I can leave it for 2 weeks, and I only change the outer layer, and that's the only dressing. And then you open it all up, and it's all healed. So it's really good. Just one dressing, one really good dressing. Okay, and of course, I think you all have silver sulfadiazine in your clinic, which is really good for burns. It's anti-pseudomonas and it cools the burn and it takes the sting away. So it really is good. The only thing about it is that it causes a pseudo eschar. So if you're going to use silver sulfadiazine and use it for 3 days, and then after that you decide, I better send to the doctor in the hospital. At that point in time, I can't tell the depth of burn because there's this eschar on it already. So I don't know whether it's a superficial partial thickness or whether it's a deep partial thickness and whether I need to graft or not. Okay? So if you think you are not going to be managing it, don't use silver sulfadiazine. Other things you can use, especially for face, liquid paraffin, chloramphenicol, Mebo, whatever. Then your secondary dressings. This is the things that you need to soak all the fluid that is going to ooze out because of all that the cells move apart and then there's all these seep of fluid into your third space. So it depends on what you like, what you have, what's available. Just make sure it's done properly, that you maintain range of motion on your limbs, okay? And that you stick it down properly so it doesn't move. Because if it moves and your dressings, your wound gets exposed, it's a waste of time and money. Okay, you need sure it needs to, it's a patient picture that I took when I was in UH. You can see that the dressing that's supposed to be right over has just moved up because they didn't secure it properly. Okay, this is how you're supposed to secure a dressing. And then for the foot, you just wrap around the toes and then the patient walk and it just goes flying away. Okay, so it's supposed to secure around an ankle or hold it down. Okay, I wasn't going to go into this unless I don't have time. I was going to talk for 15 minutes and give 5 minutes for question. Is it? Okay. So then there is surgery, which is where me and Dr. Jeffrey come in. Okay, so there is like acute surgery for deep partial thickness, full thickness burn, and then there's secondary reconstructive surgery for scars and things like that. And then rehab. So this is done for deep partial thickness and full thickness burn. This was a patient in the UK who had an epileptic fit and fell against the radiator. And because he lived on his own, after he woke up, then he was like, oh, what happened? And because it is full thickness burn and the nerve endings are dead, he doesn't feel any pain. So he goes around for a few days until he starts to smell. And then he wonders why it's smelling and then it starts oozing. And so this is like, you can see it's down to bone. Okay, that area, that's bone. So this one needs a flap. Okay, and so you need to do early. You need to get rid of dead skin, dead tissue, and you need to do proper dressings. Okay, secondary surgery is when they end up with contractures or causes problems. Okay, so usually we wait until the scar is mature, but there are different caveats. So we usually decide when to do what to do depending on function. Okay, so this is with release with multiple Z-plasties, and then we do a full thickness. Rehab starts as soon as possible. As soon as the patient comes in, when even you have a dressing for the hand, I usually get the physio to come and move the hand, because even if your hand, the skin is healed and you haven't moved, then the hand becomes stiff. It's going to be useless. So you have to exercise. They need to move their fingers, move the thumb, move the wrist, okay? And you need to make sure that they don't lose muscle, because they just lie in bed, they're in pain, and they don't move, then you lose muscle. And then when it's time for them to get up and go, they can't. They've lost so much muscle, okay? So it needs to start immediately, as soon as they come in, not wait until they are healed, okay? So there's physio and there's occupational therapy, all right? For neck burns, I don't give them a pillow, because if it's down here, then if you give them a pillow, it's going to be contracted. So usually I take away pillows, no pillow allowed. Okay, so you don't want a contracture like this, all right? So after burn care, you need to look after your scars. Most skin grafts and most burnt skin, newly healed skin do not have the sebaceous glands and all those things to moisturize themselves. So if it dries up, it will crack, and then you have a new wound. Okay, so you need to put moisturizing lotion and you need to massage. And the massage is not how you like urut and press on it, because that will cause more blisters. It's a gentle, like rolling, pressing on it motion. You need to put sunblock so it doesn't become dark. There's all this post-inflammatory hyperpigmentation, but there's also, because it is new skin, it is fragile and it will get sunburn easily. So you really need to sunblock. And then of course there's silicone gels, and then there's pressure garments and all that exercise. So this is an example of a pressure garment. Okay. So now, any questions before? If I have time, I can move on to understanding why we do what we do at the end. Okay. No burning tongues. Okay, so to be able to tell the other provider, healthcare provider, about a patient with a burn, you need to tell them all the things that are relevant and necessary, and you classify burns according to 3 different things. Okay, so there is all these ways. The most common is a thermal burn, but there are other ways of getting burn, and I'm not going to go into all of it. Then, so in the past, we used to talk about 1st degree, 2nd degree, 3rd degree. That's very old-fashioned, and unfortunately, the ATLS hasn't caught up, and all the books in the ATLS still talk about 1st degree, 2nd degree, 3rd degree. But burn surgeons talk about superficial burn, which is like a sunburn, okay? And then the next is a partial thickness, and the partial thickness is then divided into superficial partial thickness and deep partial thickness. Your superficial partial thickness is where you've blistered, your skin is light pink, it's very oozy, and it's very painful. Okay, and then this is your deep partial thickness, where it's a lot deeper, it's gone down to your reticular dermis, and it's not going to heal on its own unless you, most of the time you do a skin graft, but it depends, because they're varying depths, and some of it is deeper, some of it is not so deep, and different people have different healing properties. Okay, then this is a full thickness burn, where all of the layers of your skin is burned, so there are no more skin elements there to help grow and epithelialize anymore, and you need to cut this off and put a skin graft on. Okay, so this is a full thickness, the white, it's white and leathery, and then the surrounding area here is deep partial thickness. Okay, so this is deep partial thickness, this one is all full thickness. Another example of full thickness burn from flame. Okay, so then how you decide on the size, there are different ways of doing it. The quick one is to do the palm size, and it's not your palm size, it's the patient's palm size. Okay, and then the rule of 9s is another quick way for estimating. So one torso, the front is 18%, the front of an arm is 4.5%, but the whole limb is 9%, and then the whole of the front of a lower limb is 9%, and that's how you estimate very quickly. But the most accurate way is using the Lund and Browder chart. Okay, so you draw on it and then you work out according to the age and where it is. Okay, so this is the more accurate way of assessing a total burn surface area. And there's a separate one for children up to age of 10. So when do you refer? When you have a major burn, okay? Major burns, actually big burns is when it's more than 30%, but I would say around 25% is relatively big as well. But anybody, any adult, anybody above 15 to 50, more than 15% burn, you need to resuscitate. Below that age and above 50, if it's more than 10%, they also need to resuscitate. So they need to be in hospital because we don't have the good social home care where the nurse can come and give them IV fluids at home. Okay, so they need to be in a hospital, but they don't need to be in a specialist burn unit. Okay, burns to special areas should be admitted. So the special areas, your face, your neck, your genitalia, your hands, and your feet. Okay, so significant electrical burns, if you're not sure the voltage, anything below 1,000 is not so bad. Above 1,000 is really bad. And then significant chemical burns. Don't lie, you dip a finger and then you come to the hospital for that. Inhalational injury needs to come in because they might lose their airway. If you have full thickness circumferential burns, you might cut off the blood supply to the distal end. And then patients with other medical problems, diabetic, hypertensive, heart disease, and then patients with other injuries like fractured pelvis, crush injury, stabbings or whatever, and splashing of acid or whatever. And always, always, always suspect non-accidental injuries. It's not just children, it's also the elderly and people who are unable to look after themselves, the mentally handicapped. Okay, so you need to be aware and always have it on the back of your mind. Okay, so first aid is really important. It's so important because you can cool a burn, you can reduce the depth of the burn, you can reduce the size of the burn. Okay, and then you need to refer early. Don't wait until a really bad scar has formed and then you're really struggling. Okay, and then you need to do your dressings properly, otherwise it's of no bloody use. Okay, then you need to prevent burns. Okay, make sure your house is safe, make sure your kids are safe. All right, okay. All right, thank you very much.
Thanks. All right, thank you so much, Dr. Margaret. Please save your questions because we will have a panel discussion after this. So we would like to invite Dr. Jeffrey Chan and also a consultant, plastic and reconstructive surgeon from Sunway Medical Center to give his thought about a plastic surgeon perspective, skin cancer. Dr. Jeffrey?
To start. Good morning, and thank you, organizing committee, for inviting me to give this talk, especially to Dr. Betty Tay. The focus of my talk today is on skin cancers and also difficult wounds from a plastic surgeon's perspective. So this talk is more about cases rather than there won't be too much theory today. So try to not to take photos or videos if possible. So plastic surgeons are usually associated with aesthetic surgery, but there's a whole bunch of other subspecialty fields that we do. You might know about dermatology that we talk about today, burn surgery, Dr. Margaret just discussed, facial or oculoplastic surgery, cleft surgery. But we also do the torso, breast reconstruction, chest wall reconstruction, the back, abdominal wall, head and neck cancers, hand surgery. I myself is a hand surgeon. We also do orthoplastic surgery for the lower limbs, such as open fracture where there's missing skin, perineal reconstruction, and so on. So the purpose of this talk today is to demonstrate the scope of a reconstructive plastic surgery surgeon in the management of skin cancers as well as other soft tissue defects. I will showcase you some of the common and also some challenging cases. Hopefully this will not put you off your lunch later on. Some of these surgeries are multiple stages, but I've simplified them in this presentation to aid understanding for a general audience. So what is reconstructive surgery? This is a repair or replacement of a physical defects to restore form or function. This can be the transfer of skin, muscle, bone, fascia, tendon, or even periosteum to help wound healing. And there can be structures in the hand, the face, the extremities, and so on. Most of the cases we receive in hospital like Sunway Medical Center, which is a big quaternary hospital, are salvage cases from other specialties. So they have operated on this patient multiple times and they can't move on. They want to pass it on and they will end up to us. So we have to be skilled in the use of grafts, which involve normally skin grafts, but also tendon grafts, nerve grafts, occasionally cartilage and bone grafts. We are skilled in the use of flaps. This can be local flaps, pedicle flaps, regional or distant flaps. I'll give you some examples later on. And we're also skilled in the use of skin transfer or microvascular free tissue transfer, where we remove a piece of tissue with its blood supply and then move to a different anatomical region. The common skin cancers that we see at the top, basal cell and squamous cell carcinoma. The more serious one, malignant melanoma, less common in Malaysia, but very common in the West where I used to work. Dermatofibrosarcoma protuberans, high rate of local recurrence. Very aggressive tumors such as angiosarcoma and Merkel cell carcinoma, high risk of mortality. And something with very challenging reconstruction difficulty, such as sarcoma involving skin, muscle, and bone and other structures such as nerve and tendons. The list on the right are other things that we also do, which I won't discuss. So in terms of reconstructing defect or a wound after an excision, this is my guiding principle. So we have to know what is the diagnosis. If we don't have a biopsy, we have to be suspicious. Is it a benign condition or is it potentially malignant? I send everything for HPE, and also if there's infection, I send for micro. Even a simple lipoma, I will send for HPE, because sometimes you get a surprise and you don't have HPE or tissue for further studies, and the tumor is already removed. If there's any concern about malignancy, I will do a scan, such as PET scan, to look for lymph node metastasis or distant metastasis. In my mind, I would already have defined the lesion, how big would the lesion or the defect after excision will potentially be after a cancer margin is taken. Options of reconstruction, like I said just now, local flaps or skin graft or microvascular tissue transfer, as well as what other structures I might need, such as tendon in the hand. I will show you some cases later on. So our operations are not scarless. This is a question that I get every time there's a new patient come to my clinic. But we do plan optimally, execute the surgery effectively, and manage the scar with a lot of attention. So we place our scar in the optimal place so that it's fairly hidden. We manage our wound closure so that there's less wound adhesions, and also we manage the wound dressings. Usually I don't leave it to the nurses unless it's a very simple thing. So in surgery, we pay attention to tissue handling, wound healing, and post-op care, and also post-op scar management. So this is a very simple case, a lipoma on the flank. It can be managed with 1/3 the size of the lump. So you don't need to make a long incision just to remove this. With meticulous dissection, you can, generally speaking, take this out in about 30% of the length. This is another case, a big lipoma on the shoulder can be removed with, about 1/3. Even though it's a multilobular tumor, lipoma, it can be removed with a short scar. This patient has the osteoma on the forehead, very common thing. You can remove it without any scar on the forehead. The trick is to do it from further away in the hairline, so that when she recover and have her hair combed down, there will be no scar visible on the front. This is how we place our scar, and we hide to get a better and optimal result. So this is a lady who is 4 months post-excision of a basal cell carcinoma on the eyelid. And can you find the scar on this photograph? So this lady had a basal cell carcinoma there on the lower eyelid. She had it excised with a 3 mm margin. So that's about 1/3 of her lower eyelid skin. So we do an advancement flap from the lateral side of the eyelid and the temple area. And after a couple of months, it heals without an obvious scar. Another case, this guy has this lesion for 1 year approximately. I scolded him when he came to my clinic. I asked him, why do you leave it for so long? So this is a biopsy-proven basal cell carcinoma. It has to be excised with a fairly big margin, so I took 4 to 5 millimeters to ensure all the margins are clear, including the deep margin. So you can see it's cut down to the cartilage and the muscle on the cheek. Because it was Hari Raya at that time, so he didn't want to have his second surgery done quickly. So we excised this, we leave it for a couple of weeks. He celebrated his Hari Raya. And then we did a forehead flap. So there's a flap that is taken from the forehead on its blood supply and then transferred down to the dorsum of the nose and also the right side of the cheek. This is left for approximately 3 to 4 weeks. So after surgery, he walks around like this for a couple of weeks. And this flap, the blood supply from the cheek or the base of the wound will start growing into this flap. So after a couple of weeks, we can chop this off. And then the piece of skin that originally comes from the forehead will now end up here surviving. So this is when the swelling and all the bruising has come down. And you can also see that his forehead has started to heal. And this is after approximately 3 months. The flap that you can see here is still a bit thick. I've advised him to thin it out to give it a better contour, but he's not keen for the moment. But overall, this is a very good result given that with what he presented. This is a Caucasian patient with another biopsy-proven basal cell carcinoma. It's not as big as the first one. So we did a local flap. So we just do a dorsal nasal flap that moves the entire dorsum of the nose down. The tumor is excised with a 3 mm margin. You can see his bruise black, doesn't look very good. We remove the suture early to prevent suture marks. And this is how it looks like. It's like nothing happened to him. Maybe you can see a little bit of scar here. and a little bit here, but this can be revised. It looks like his glabellar lines. There was him before, and the middle picture is him after. This is another non-healing ulcer on the forearm. Is a basal cell carcinoma. This typical story where an old auntie will say she have a scratch or she have a hot oil splash or mosquito bite and it never heals. They're sort of in denial that they have skin cancer and very slow to see GPs and always visit pharmacies and sensei to use creams, etc. But skin cancer need to be ruled out. So this is a skin cancer, basal cell carcinoma. So I did a local transposition flap. You can see the cancer is excised down to muscle fascia here. And we even preserve the small cutaneous nerve here. And then we turn the skin flap and cover the wound. And that's the result on your right, approximately 4 weeks after surgery. And heals very well. This is another case of it's a salvage case from orthopedics. It's always from orthopedics, almost always. There's a chronic ulcerative lesion on the back of the Achilles tendon. Patient had previous Achilles tendon repair. You can see the scar here, old scar. And this wound has broken down. You can see some green material there. That's the stitch that the orthopedic surgeon used. And today I learned a new term called the fish scale appearance here from Dr. Lee. And you can see the foot is chronically swollen, discolored, doesn't look very nice. And this patient been going from one doctor to another, and somehow he came to Sunway Medical Center. And during surgery, before surgery, I actually told him I will excise the whole thing. No point faffing around with antibiotics and many INDs. So I cut out the whole thing, as you can see there. You can see green stitches. These are all braided stitches, very prone to infection. So we use an anterolateral thigh flap. This flap, as the name suggests, comes from the thigh. We raise it on its vascular pedicle here. And the vascular pedicle then will be chopped off, and then the whole skin flap transferred to the ankle, and anastomosis under the microscope is done. You can see view under the microscope, artery and 2 veins connected. And this is his result after 3 months. You can see the skin is soft, it's elastic, you can pinch it almost. And he's good range of motion. And recently he's gone traveling to China because he imports fruit, and I think some of your mandarin oranges maybe comes from him. So that's before and this after. So this auntie again, I have a chronic non-healing wound for the last 15 to 20 years. She had a previous open tibia fracture. Very vague history, not sure whether the skin over the fracture site ever heals. She's from the border between Penang and Kedah. So for something like this, you have to suspect whether the wound has undergone malignant transformation. So for this case, it did. So this is a skin cancer from a chronic wound. A benign wound has turned into a cancerous wound because of chronicity. It's also known as Magellan's ulcer. So you have to think about this when something doesn't heal. So there was also another surprise. When we opened the wound, you can see these things, maggots in the wound. This was the first time I ever vomited in front of the patient. So we did a cancer type excision with margins. You can see we excised down to tendon. And then we do the same flap that we did for the ankle. But this time we have to shape the flap to the defect on the lower leg. So we have this flap We have two vascular pedicles on the same main pedicle. We cut the flap into two, shape it to the shape of the wound or size of the wound. And then we put it on. Vascular anastomosis is done on the posterior tibial artery and vein here. And this is her after approximately 1 year. The flap, because it's from the thigh, is a bit bulky. I have advised her to debulk it. That means we can lift the skin flap, take out some of the fat, and then put the skin down again so that it's contoured better. But she declined this, very happy with the result. So I'm still following her up for her squamous cell carcinoma. There's no more maggots. So this is a range of movement. Okay. Dr. Margaret talked about burn injury just now. This is our shared case. This patient comes from Indonesia with a high voltage electrical burn from the roof or the line that comes into the house. This was approximately 6 months ago. You can see the burn wound actually almost healed. But you can see the shape of the hand. There's loss of muscle. There's muscle wasting. The hand doesn't look round anymore. It looks more like a square rectangular shape. The hypothenar and the thenar muscle are all gone. Even the interosseous muscles are gone. That's all he has. He has no range of motion of the fingers because the long flexor tendons have ruptured. He also has some numbness in his fingers because the nerve was burned or ruptured due to infection. And you can see also he likely have compartment syndrome. His forearm is very thin, probably has a lot of swelling from the electrical burn, and then the swelling causes ischemia of muscle causing fibrosis of the forearm muscles. So another video again showing his range of motion. So we like the thigh, so we use the anterior lateral thigh free flap again. In the thigh, we also harvest the tendon fascia lata as tendon grafts to reconstruct his forearm tendons. You can see here, all his tendons. These are the tendon ends at the proximal part. These are the tendon ends at the distal part. There's also nerve, partial part of the nerves divided. This is the long flexor tendon, flexor pollicis longus of his thumb. So we harvest a very massive flap because we wanted the soft tissue. And also you can see here, stitches here. The tendons has been repaired with like a 5 to 7 centimeter tendon grafts. The skin here is the skin that we taken from the thigh. We did microvascular anastomosis down here to keep the flap alive. The reason we needed a thick piece of flap is because this area is very scarred, and the tendon grafts that we put on, if it's in an unhealthy region, with poor blood supply, then the tendon grafts will either rupture or become adherent to the surrounding tissue. So we want this fresh, fatty tissue to wrap our tendon around so that it doesn't cause tendon adhesions and provide a gliding surface. So that's very important. You can't just simply put a tendon into a polyvascularized site. It will just get stuck down. So this is approximately 4 months after surgery. You can see the wound has healed well. The forearm is a bit bulky. That is the nature of the procedure. But he has very good finger flexor. So he can flex his fingers now from what you saw before. So now at least he can carry a shopping bag. We also did some work on his thumb later on as a second stage. So let's move on. This is a case of a very aggressive malignant melanoma on a 20-something-year-old, very young girl. You can see the nodular dark lump on the plantar heel was excised by her I'm not sure, dermatological surgeon or general surgeon, with a very narrow margin. And you know that the heel doesn't move. So when you primarily close this wound, of course it's going to break down. So she presented to a dermatologist here with wound breakdown. And then we realized her management of melanoma is very poor. There's a full guideline on the American Cancer Society or the British Cancer Society on management of melanoma. So the right way to do this is to take a 2 centimeter margin down to the next layer. So I took it down to the periosteum of the calcaneum. You can see how thick this is. I also do a central lymph node biopsy, turned out to be negative, so there's no spread to the lymph node. You can see here, there's bare calcaneum bone, no more periosteum. So how do you reconstruct this? So you need something that has sensation, because if you just put a free flap like the other cases, there's no sensation, patients start walking and the wound will start ulcerate and break down from rubbing or from lack of protective sensation. So we use a medial plantar flap. So I harvested a flap with the nerves. So this flap has nerves going into it and its blood supply also going into it. And then we flip it there to cover the heel. And then for the second, for the donor site defect, we use a simple full thickness graft from the groin to put it there, here. So this is how she healed after approximately 6 months. She has full sensation here, no ulceration. You can see here very nicely. The skin graft is pigmented, but also healed well. So this is how you should do it. This is the case when the initial biopsy, the initial HPE showed a SCC in situ or Bowen's disease. Rightfully, the referring dermatologist was concerned and referred to me. You can see that there's some biopsy stitches here. So maybe the main lesion was not biopsied, and this might be in situ disease and this might be invasive disease. So I took the patient, do a wide excision down to the next layer, the muscle of the skin, make sure don't cut the nerves. We do a big flap. It's almost like a reverse facelift. He suffered some small hematoma because he was on aspirin, but he eventually recovered like nothing happened to him. And this post-op picture here, you can see scar here, but not very obvious. The most prominent one was here because I opened it up to drain some hematoma. This young man has a stony heart lesion, so we did a local flap. I just moved quickly for the interest of time. So local flap turned on and his good range of motion. Another defect here from a burn from neutropenic sepsis, but I don't use a local flap because you can see the surrounding tissue is very inflamed. So we use a free flap. Her hand also very stiff. We use a free flap from the groin. Put it on the arm, did microanastomosis on the wrist level. And then this is her range of motion after. I also treat hidradenitis suppurativa. I won't go too much because of time. So my preferred method is to excise everything and do a local flap to let it heal, to get rid of the disease. This is a dermatofibrous sarcoma we take out with 3 centimeter margin to reduce high risk of recurrence, local flap, and this one heal. Pressure sore, maybe I skip that. We excise it like a tumor into bone, then we use soft tissue to fit into the defect to allow healing. And this is how it is afterwards. Palliative surgery. So some people will have the opinion that we don't operate on patient who has very poor prognosis, but sometimes you have to do that. This tumor has almost invading into the axilla, so we have to do a wide excision, not for survival long term, but for wound toilet, for quality of life, for pain control, etc. So we took a big flap, a super gigantic flap from the tummy, did our microanastomosis. We did 8 vessels, the most I think we have done here in Sunway. Put it there on the chest just to cover the wound. It's not a cosmetic operation. It's more like a chest wall coverage. Just happened her tummy has the biggest donor site. So what about very small defects? Can we do that? We listen to Dr. Lee talking about some nail conditions. This guy had an accident to the nail. Some of the, I think, skin material gone into the nail. He suffered inclusion cysts. You can see there's a hole in the distal phalanx of the bone because the cyst, high pressure from the cyst has eroded the bone. So when we open this, there's cyst material here, and then a big hole. You can put your instrument and you reach the other side. So I do a very small flap from the wrist called the supra flap, not Toyota Supra, not the car, but supra flap, superficial branch of the radial artery, free flap. And this flap, I anastomose the artery here and vein here. The artery I anastomose to the digital artery of the finger and the vein to the back, the vein at the back of the finger. And after about 1 year, he heals very well. You almost cannot see the donor site on the wrist. The nail is gone, obviously, but the finger has healed to a very nice shape because the flap used was very thin. I just briefly go through lymphedema. This will be my last part. We also manage lymphedema. Usually it's non-surgical management, as you all know, compression, mechanical pumps, etc., psychological counseling. Recently, we are going to acquire this ICG machine to view the lymphatics. This is my own hand. I injected it with ICG, and you can see that the ICG fluorescent dye has traveled through my lymphatic vessels. I can milk it up my leg. You can see that. So it is very important for surgeons who operate on lymphatic ducts because you can do this. This is a patient who suffers from lymphedema, has her ICG done, and you can see the pathway of the lymphatic vessels. And under the microscope, this is the dye has leaked out to everywhere because of severity of the condition. But you can look for lymphatic vessels and the vein, and you can do a bypass. So now the vein, the lymphatic fluid from the lymphatic vessels now connected to the vein will drain up using the vein. That's why it's called a bypass. So this is a patient who recently had surgery. You can see the left leg has almost decompressed. Very wrinkly skin because all the fluid has been bypassed up. So I end my talk here. Sorry for the delay. So our skin defects and our surgeries sometimes can be challenging, but it's also very rewarding because every defects are different. We have to be creative. We have to make up our surgical plan. Sometimes plan A doesn't work, we go for plan B. Thank you very much.
All right, thank you so much, Dr. Jeffrey Chan. Now we will invite Dr. Jeffrey, Dr. Margaret, and also our moderator, Dr. Betty, to be on the stage for our panel discussion. Please, whoever online, please throw your chat in our chat box. And please, whoever here, please raise your hand if you have any questions for Dr. Jeffrey and Dr. Margaret.
Hello.
Yep.
Are there any questions from the floor? I would really appreciate it if you can silence your phone and silence your voice while the speaker is speaking. Any question on the floor? Okay.
One comment first, excellent results from your surgery. The other thing is, I want to ask, do you do more surgery for basal cell carcinoma in places like near the eye, near the nose?
I don't do more surgery. I just do slow-mo. That means we excise the lesion with a adequate margin, and then we send for regular histopathology, and then we come back another day for reconstruction. Usually after 1 week when we have the result. But I don't do more surgery because usually the defect will be much bigger than the lesion. I still not convinced. They use frozen section for the more surgery to decide how much more they take, and every time it's not enough, so they take more. So a 1 centimeter BCC can end up with a 6 centimeter defect. So I don't do that.
I think we should, yeah, the results are extremely good and these are not easy surgeries. Both of them do marathon surgeries. How long is your longest surgery, Margaret, Jeff? And they always, they are like partners in crime a lot of times. How long is your longest surgery, Margaret?
I think 28 hours for me. I don't know about Margaret.
Yeah,
For me and
28,
Margaret, our shared
20
case.
28 hours. And sometimes the surgeries are not, you can't go as planned and they have to think on the spot, yeah? So we take the first question. For the first contact with primary care in a burn case, is it okay to use the cling film to cover? And again, can I please ask you to silence your phone?
Yes, yes, you can use cling film, and then after that send on to wherever. Just make sure that they don't decide to go somewhere else.
Okay. A lot of people's concern if the burn is a bulle, do they rupture the bulle or just leave it?
As I said, there are caveats. If it looks like it's getting bigger and it's about to break, then there'll be a whole pile of fluid and mess. While the skin is there, it protects it and it's less painful. So it depends on how fast you're going to be getting to a healthcare center to get your wound looked at. If it's on the usually on the front of your hand where the skin is thicker, that one can be left because it's unlikely to burst and it works like its own dressing. So you can just leave it and leave it and leave it, and then the fluid in there will get absorbed, and then later on you can just trim off the dried skin and it's all healed underneath.
Okay, there is a question from the online which, how can we recognize impartial thickness loss clinically? How to recognize impartial thickness loss clinically? I don't.
Oh,
Yeah.
okay. So if it's a superficial partial thickness, it's usually light pink and it's usually moist and very painful. And then when you press on it, it blanches. Okay, but the deeper partial thickness, it tends to be darker red, more mottled, and it tends to be drier. And then it doesn't tend to blanch. But there are varying grades of it. So you need a little bit of experience looking at burns to decide.
Okay. Somebody asked whether the treatment for chemical burn is similar to regular burn.
Yeah, you just have to wash a bit more. Acid burns and alkali burns, usually I would take a litmus paper and I would test it. So if it's an acid burn, I use a blue litmus paper and I check and see whether it turns pink. If it is, I continue to wash. Alkali burn, then I use the reverse. I use a pink one and I make sure it doesn't turn blue. They tend to, I've had to wash them sometimes for 24 hours before I do a dressing because sometimes it's still there and you need to really wash. Rewash and wash and wash until it's all gone.
Okay. For non-healing surgical wound, what type of time frame and indication would be a good time for referral to plastic surgeons?
Sorry, what kind of wound?
What non-healing surgical wounds?
Oh, 2 weeks.
Yeah, maybe give it a chance 1 week, and if there's any sign of infection, take a wound swab and start on prophylaxis antibiotic. But if it's not settling down, there's no point waiting. Maybe this will need debridement and resuturing. Patient will recover much faster and also have a nicer cosmetic result.
Is a referral to plastic surgeon actually covered by medical insurance?
Depends if it's for a good reason, usually it is. I mean, things like the cancers, they will be covered. Things like the burns, infection, yeah, they're covered. But
Okay.
it's for pure cosmetic, like you don't like your mole in covered, okay?
What's the principle of scar care and how to keep it as seamless as possible?
Every plastic surgeon have their own habits and methods. Generally speaking, I will use silicone gel. I use a sunblock SPF 50 or higher, maybe a moisturizer also. I ask the patient to massage 3 times a day for a few minutes. And I generally will ask the patient to tape the scar with a micropore tape, or if they can afford, using a silicone sheet patch. So it depends on the location. Some places, like near the hairy areas, you cannot do skin taping. But this regime, I ask them to do for at least 3 months. If they want the scar to look nice, they have to work hard. Nothing is free in this world.
Nothing is free. Okay, this is a very interesting question, and I think I also like to know the answer, because when I was a house officer, there was a very large wound with maggots. So, what is your opinion on maggot therapy? I'm not sure whether the question is whether to use maggot as a therapy or to treat wounds that has maggot. So whichever you look at, you can answer that question.
Actually, maggot therapy it's there, and we have it. And I think you can actually get the maggots from the research institute in KL. And it's good for debriding wounds where you don't want it to be painful, because the maggots can just eat all the dead tissue and it doesn't hurt, and then once they're full, they just fall off, but they grow new ones. But for us, it's like, Jeffrey, I mean, you really get sick. I also had one, and all my registrar, my MO, all ran away and left me to deal with it. It's really not very fun. But yeah lah, it can be used. It can be useful for debriding, but for us, that we don't really want it, so we have to get rid of it.
Yeah.
You use paraffin, isn't it? It's kerosene or something like that. You
I
pour on it
had
and it comes off. Yeah.
the house office as a house officer. I had this 90-year-old with I think a basal cell carcinoma near her eye, and then we took her to OT, and then we shined the light, and then there were the maggots just popping. I nearly fainted. I tell you, I couldn't do the case. And we rescheduled her, and my colleague tried to do the case. I don't know what happened actually in the end. I think we will break for tea.
Yep.
Okay, for a short break, and then we'll come back and continue our session. The numbers are increasing, so please feel free to come forward or find some empty seats in between, and also enjoy your tea and coffee. And we'll see you back at
10 minutes.
about
Can we have a 10
10:15.
minutes? Yep, thank you so much, Dr. Margaret, Dr. Jaffrey, and our moderator, Dr. Betty. Please have a 10-minute coffee break.
11:15, sorry, 11:15.
Yes, have a 10-minute coffee break. So next, we have our speaker. We would like to invite Dr. Ungku Muhammad Sharin. He's a founder and program director of Medical Aesthetic. He will talk about rejuvenating the skin in postmenopausal women. So without further ado, please welcome Dr. Ungku.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone. First of all, thank you, Dr. Betty, for inviting me. I guess I know here Dr. Margaret and a few new friends. Okay, no, I just need to remove this because it doesn't work. Should I put quit? doesn't really. Okay, thank you. So, a little bit about myself. Actually, when I was invited by Dr. Betty, knowing her, I think we are friends in Facebook. Knowing her that she is a cardiologist by profession. So I wonder, why she is inviting me. This really cardiology is not my forte. But then she posted that this is regarding skin or skin symposia. So, and I called her, I asked her, I guess this is part of her contribution through the Beating Hearts Association. So I guess that's where I come today to give or to deliver my talk. A little bit about me. I am chairing the Usmari Research and Innovation Center. What is Usmari? Usmari is a research center dedicated to do research on aesthetic, regenerative medicine, and also cosmeceutical. So this is a privately funded research center for the past 4 years. We publish a lot of papers. We do research up to RCT level. And we also helping Ministry of Health to conduct certain clinical trial and research survey, for instance, during COVID, regarding public awareness, for instance, in aesthetic medicine. I'm also the president of Pertubuhan Doktor Estetik Berata Malaysia. We have about 800 members under us, and this is mainly for chapter 1. May I know, before I start my talk, may I know how many doctors here? Can you raise your hand? Okay, 3, 4. And the rest are, majority are paramedics, patients. Is there any, like non-medical? Okay, all right. So I will try to cater, in terms of the terms that I'm going to use today. So today my topic is rejuvenating the skin of post-menopausal women. So I guess I don't want to go to the detail about postmenopausal. I guess everyone should know what's the age like or age range for postmenopausal women. But before we go any further, I think it's best for us to at least know what is the aging process. This is a refresher for those audience or non-medical. I guess I give my explanation in brief, actually, where somebody asked me in social media about aging process, and I told them you will start aging the moment you are born, actually, whether you like it or not. So, and normally at the age, or on average at the age of 20 and above, we start to age by 1%. So, whether we like it or not. So it has been programmed in every individual DNA. We cannot hide, we cannot run from it. And by understanding the aging process, we could anticipate physical changes in our face and body. This is where we guide us to undergo a more meaningful aesthetic medicine procedures, as well as realistic expectation. I want to enhance or emphasize on this realistic expectation, because when I see my patient, not only from me, from all my colleagues, actually, they will say that some of the patient that comes to them sometimes request unrealistic expectation or result. Yeah. Until now, for instance, there's no such treatment that can claim that they can reverse or make my gray hair dark, for instance. So you need to know that there's always a scientific evidence to back every procedures in aesthetic medicine. And regarding aging process, this is a refresher for medical doctors or medical personnel. There's two factors actually in regards to aging process. One is biological or internal aging, which we can divide that into, Okay. It's on again. Oh, not a problem. Sorry, technical difficulties. So I just going to share a little bit about biological or internal aging. You can divide that into chrono aging, which is the internal aging. This is where it's predetermined by your, hold on. Okay, I'm going to continue again, even though we are having some technical difficulties. One is chronoaging, yeah, or under biological aging, which is genetically predetermined, such as metabolic disruption, lower cell enzyme activity, that will slow healing process, such as and lower the collagen production. Hormonal aging is due to decreased reproductive hormone, such as that estrogen in ladies, leading to skin dryness, wrinkle, enlarged pores, abnormal skin lesion, such as pigmentation and vascular lesion. And another one is external aging, which is related to ultraviolet, pollution, food that we eat, smoking, or alcohol consumption, and etc. So these are among the things that there are the factors of aging in every human being. No, no.
Sorry about the glitch. There is a QR code for a quiz. There's a 20-question quiz that you can actually get the QR code from the, and then when you do the quiz, the top winners will get, the number one will get a tablet, and the second winner will get a handphone. So, yeah, so you can please try the quiz. Of course, the speakers cannot try the quiz. Okay. Sorry about that. And I would please do appreciate if you don't use your handphone and silent your handphone. So this is the quiz. You can, yeah. I think if you have any skin interest, you will be able to do it.
I think just give us another 2 to 3 more minutes. But before I go, while waiting for that, I just want to share with you when I started aesthetic in year 2002 until now. 2002, when I started my aesthetic journey or aesthetic medicine journey, I think it's very preliminary in Malaysia. I remember my patient comes to me and keep mistakenly thought that I'm an anesthetic doctor. Pakar abuse. No, I said, I'm not an aesthetic doctor. I'm an aesthetic. What is aesthetic? So, during those days, 2002, I go fully aesthetic, and there's nothing much we can learn here in Malaysia because there's not too many doctors doing it. So I have to go abroad. I travel to a lot of countries, especially in Europe, to know more about aesthetic. And as time goes, I noticed that during those days, the preliminary days, we are using procedures or treatment are so rudimental. We are talking about Botox, toxin injection. We are talking about fillers. Even the dermal fillers that we use during those days are coming from bovine collagen. So it can cause a lot of allergic reaction to our patient. They even use cockerel comb. Cockerel, that ayam atas yang warna merah tu. So they use that, they process and use that as a fillers also. So yes, at that time, in 2002. So we have to import it from US in order for us to get to inject our patient. And as time goes, they start to go very niche. At that time, we only know dynamic wrinkle and okay, now we got on track. Otherwise, I have to make jokes and comedy, what do you call stand-up comedy, just to fill up the time. Okay, thank you. So, okay, back to this, yeah. So when we talk about aging just now, two main factors: biological aging. You can't really change chrono-aging, ladies and gentlemen. This is genetically predetermined, metabolic disruption, lower cell enzyme activities. So it's happening to every one of us. And I don't know how many of us here already reaches, especially the ladies. I don't know. I don't think any men reach any, menopause or what they call andropause now, which is the definition is still vague and nobody can define that. But menopause is very common. I mean, is what known to the public. So you're going to reach this. For those who have not reached that age yet, you may reach this. Hormonal aging, estrogen lower down. External aging, as I mentioned, because of ultraviolet radiation, smoking, pollution, etc. So these are the things that may affect skin aging. And I always believe before you undergo any medical aesthetic treatment or aesthetic treatment for that matter, you need to understand what are the changes that you may see. For those who already gone through that, this is the time for you to see and to probably assess whether you already reached to that process or not. Skin, there's a lot more actually, but I just want to focus on bone, fat, and skin. And we'll talk about changes in aging for the bone. You will notice as we reach menopausal age for the ladies or even for guys, when you reach certain age, there will be a posterior displacement of the maxilla, posterior displacement, going backwards, lateral inferior shifting of orbital rim, lateral and inferior, side dan ke bawah for those who are non-medical. So that's where you see our grandmother, their socket is even deeper than usual. They look like as if they have panda eyes or dark circle. No, it's not that, because just that there's a bony changes actually. Shrinking of the mandible in the vertical and horizontal plane. The mandible tend to become smaller. When the mandible is smaller, so this is where, you will lose your jawline definition. And when talk about changes in fats, hypertrophy on the superficial fats due to decreased vascularity, and hypertrophy on deep fat layer. You see that this is what we call depot, due to slowing down of metabolism after the 4th decade of life. You're going to see that the fats become bigger internally. So a lot of my patients, we ask doctor, saya nampak makin gemuk, saya nampak makin tembam, I know those kind of words they use. So actually it's because of this, because of aging. This is natural actually. Hypertrophy or superficial subcutaneous fats. This is also something I keep telling my patient, why you want to reduce your fats so much, especially the younger one, because as we age, your fats will reduce on its own. Then we regret, you want to put, you want to do fat transfer, or you want to do a lot of treatment actually. So, and also changes in aging of the skin. I will take some time on the skin because I think this is what today is all about. So, I mean, as simple as epidermis, there will be basal cell layer turnover rate going to reduce, decline, causing thinner layer, weakened skin barrier. So, dermis, the dermis is this part for those non-medical who are in the audience today. I couldn't get the, is this the one? Okay, epidermis, this is the dermis layer. Dermis, reduction of structural proteins. Your collagen, elastin, and blood vessel become less stronger. They lose their strength, and of course, loss of elasticity, and especially decrease in type 1 and type 2 collagen. Move on. Okay, and also you're going to see fragmentation of elastin fiber, reduce skin resilience, thus increase sagging. Impact microcirculation, this resulting in a dull and cellular complexions for everyone. And this is natural actually for those who are already reaching certain age. And you need to know also there will be changes in skin, decrease in glycoaminoglycans, reduce skin hydration, plumpness, diminished sebaceous gland activities. That's why our skin, when you reach certain age, especially during menopause or post-menopause, your skin become drier, and that's where all the companies make tons of money, millions of money, because they ask you to use moisturizer, which is true, because our skin become drier and drier as we age. And hypodermis, I think, goes risk distribution with volume loss, hollowed appearance in age appearance. So these are the skin changes, and because of all the changes, fats, bone, and skin just now, this is the real facts. Whether we like it or not, we need to know that this is what we may see. Bony outline of the skull and supraorbital rim. Bony outline, you're going to see it's a bit bony, even though last time you used to be fat or chubby, and then weakening due to weakening of the orbital septum. Tortuous appearance of the muscle and brow and the temporal blood vessel. You start to see our vein around our eye area or around our head. Browptosis, this is another common thing that you may see. Browptosis, hooding of skin, and buccal hollowing also. Funny thing is that when you are young, I got patient who comes to me and asks, I look chubby, I want to remove the fats. There we go. The best solution in aesthetic currently is to do a buccal fat removal, which I think they need to do it surgically, intraoral. And knowing that actually if you were to remove it now, as you age, you're going to see that that fats actually is automatically going to go. And you're going to see that even worse following if they do it too early in their life. And you also going to see crow's feet right tights. So you're going to see that around the eye area, around here. This is what we call crow's feet, crow's burung gagak, crow's kaki. So it's like because you got that line, yeah. And then Bella crescent and esophageal groove is going to be more prominent because of due to inferior border of orbicularis oculi muscle become more prominent, and palpebral bags and tear trough. You start to have bags even though you already have a lot of your handbags or purses, but you tend to have bags on your eye area. So this is among the common things that you may see as you age. But it doesn't stop there. There's a lot more, ladies and gentlemen. Darker coloration, tight eye appearance. This is also going to happen as we age. This is something that we need to identify, yeah, due to loss of fullness between ocular muscle and overlying skin. Yeah? And somehow, because there's no specific theory or agreement in why certain people have dark circle, Certain people doesn't have at all. Certain people, they do have that even on the younger age. Some say that because of certain ethnicity, they tend to have a deeper eye socket that tend to give that shadowy, darker looking appearance on their lower eye. Some says that because there's a deposition or distribution of melanin deposition on that particular area. Some say lack of sleep because no oxygen, but nobody can prove it until now. But that's among the things that you may see as we grow older. Nasolabial fold become, because of ptotic cheek fat and leaving behind a cheek concavity, yeah? Our smiling line become deeper. You start to have fold. When you have fold like this, apart from aging, this is also, I think, due to our or your habit. Yeah, I tend to treat a lot of cabin crew, stewardess, not much of steward, but stewardess. Why? Because I guess it comes with their work. They smile a lot. They smile. They tend to have a deeper. At younger, early 30s, they start to have a deeper smiling line, which they come to us to get it injected, to make sure that their line is better. And narrowing of the nasolabial angle as piriform bone remodeling effect the alar base. It doesn't stop there. Still, aging. We don't like this, but there's a lot. Loss of the definition of jawline, as I mentioned just now, jawline, I got this type of patient, a lot of patients when they reach postmenopausal or menopausal, they, doc, it seems that I don't have any neck at all, or even jawline, because it's one line now, so which is not good at all. So they come to us for this. Facial jowls, you start to have that, we want to have younger age what they call inverted triangle. So you look sharp, triangle, look sharp. But as we age, we got that triangle which we don't really like actually. So that triangle, that's where marks the jowl part of it. Both our cheek become bigger. This is because of loss of mesenteric ligament support, reduced subcutaneous fullness. And turkey neck. It's nice to eat turkey, but not to have their neck. So, as position of the large submental fat, ptosis of the unsupported skin, chin pad, and facial portion of the platysma muscle, coupled with downward pull of platysma muscle. So, these are among the things that changes that we may see as we age. Yeah. So, in aesthetic, of course, we can't really do everything. And I keep telling some of my patients, my friends, my mother, my aunties who always bugging me, how can I look as if when they come to see me, I got a lot of aunties at home that always ask me and bug me, hey, since you are doing aesthetic, make me look young. I said, no, I don't think I can reverse that, but I can slow down I can make it better. So, well, in menopausal skin or woman, our primary objective is restoring hydration, enhancing moisture retention to combat dryness, because this is among the commonest thing, and improving elasticity, stimulating the collagen and elastin production for a firmer skin, and reducing wrinkles. Talking about improving elasticity, somehow, our fibroblasts, the cell that produce collagen, elastin in our body tend to become lazy as we age. I think they are too tired as we age. So what we need to do now, how to improve elasticity, stimulating the collagen and elastin production for a firmer skin, reducing wrinkles and fine lines, because this is what we hope to see, even skin tone, addressing hyperpigmentation, age spot. Everybody going to face this age spot, enhancing overall skin health. Also, hopefully we can strengthen the skin barrier and improving microcirculation. So this is our aim. And I'm not touching, when I was given the topic of rejuvenation, what goes into my mind, it is all non-surgical. We are talking about minimal invasive or non-invasive treatment. So now we go one by one. And for those who already reached, this is just a guide for you before you even go for any aesthetic treatment. I guess you can use this as a guideline, as a reference. On the topical aspect of it, there's a few treatments that you can opt for. One is using retinoids. This is topical, such as retinol, retinoic acid, tretinoin, etc. Adapalene is among the common one that we use. Retinoid mechanism of action, it binds with certain receptor, retinoic acid receptor, and retinoid X receptor, and activating the gene transcription. It increases epidermal turnover. Why? Because it reduces hyperkeratosis, thus promotes smoother skin texture. Ladies and gentlemen out there who are non-medical, our skin cycle, a healthy one between 21 to 28 days. As you grow older, when I mean older, as young as 18 to 20 years old, you're going to experience that your skin cycle going to become longer and longer, up to 56 years, up to 2 months. That's why you stand to see a lot of, or we complain of dull skin, as compared to our younger teenager siblings or even our children. So, and it will also, with retinol, stimulate fibroblast activity to enhance collagen type 1 and type 3, leading to improved skin elasticity. It also inhibits matrix metalloproteinases, or MMPs. So this enzyme is the one that we don't really like. We don't want it too much, actually. It's good because it will refurbish or replenish a new one, but when you have it too much, it's going to cause collagen breakdown. So we like collagen. And study shows in social media, online or e-commerce, the word collagen is so expensive. Reason being because every product that have collagen words inside there, people will run and buy. I don't know why, but it seems that that's a secret terms now. Everyone is using, my product contain collagen, this product contain collagen. Everybody will come and buy. So, and the outcomes is thicken the epidermis, reducing fine lines and wrinkles. So this is what reducing choice of word I use. I don't say that it is improving, but totally reverse, but it's improving. So, and then another one, you can also opt for estrogen-based cream. I'm sure there's a lot out there. Binds to estrogen receptor alpha and beta, in keratinocyte, fibroblast, and seborrheic, to regulate the gene expression. It increases collagen synthesis and prevents collagen degradation. Enhance glycoaminoglycans production. Just now we mentioned that it reduces as we age. We enhance that. Stimulates sebaceous gland activities. And this is also to reduce dryness. And improve microvascular circulation to enhance oxygen and nutrient delivery to the skin. So estrogen-based is another treatment that you can do. Antioxidant, vitamin C, vitamin E. Vitamin C also, become famous due to a lot of influencer out there, TikTokers, or those people who say that vitamin C is the best. So now I can say that any products that contain vitamin C is going to be sold out easily because people think that vitamin C is good. Well, it is good, but you doesn't really need to have it too much. Neutralizing reactive oxygen species or ROS that contribute to skin aging. Yeah, it stimulates fibroblasts and inhibit tyrosinase enzyme. Yeah, thus reducing melanin synthesis and prevent hyperpigmentation. All your melasma, your lentigines going to be reduced. When we talk about ROS, reactive oxygen species, for those non-medical or public members of public out there, ROS is not oxygen that we think, oxygen that we breathe. No, reactive oxygen species is a molecule that we don't like actually. What it does, how it developed from our body, when you see when you had a overexposure of UV radiation or even pollution, it can cause development of ROS, reactive oxygen species. When you have too much of this, it can cause DNA damage, yeah, which among others also gonna make or gonna reduce our protection against sunburn, again, or even causing elastin degradation or collagen degradation. Vitamin E or tocopherol works synergistically with vitamin C to provide antioxidant and stabilize cell membrane by preventing lipid perioxidation, which protect keratinocytes from oxidative damage. Yeah? So it is good. This is not the oral consumption, this is application, yeah? Cream that you can use. Hyaluronic acid, also another magic words now. Everybody is using this. Topical usage is good. When we talk last time, during my time, when we talk HA, one thing goes into my mind is only HA that we used to inject dermal fillers on patient. Now they already come up with this. Is cream form or ointment form, hyaluronic acid or HA. When I first injected dermal fillers, I told my patient I want to inject HA or hyaluronic acid. Oh doctor, saya tak mau itu acid masuk. Why should I inject acid in my body? No, HA is what you have naturally in your dermal layer. So HA, but what it does is it is acted as humectant, yeah? Meaning that it binds up to 1,000 times water. So, of course, the technology nowadays is the molecule of HA is very small so that it can penetrate on the right layer or dermal layer to be precise. Increase mechanical support and improve wound healing by enhancing keratinocyte migration and fibroblast proliferation. Yeah? Another cream that you can also use or topical application is chemical peels. Yeah, you can use AHA, alpha hydroxy acid, BHA, TCA, or phenol peels. Yeah, so this is by disrupting keratinocyte. What it does actually, for those who are new in aesthetic, chemical peel, we are playing with the skin layer at either epidermis or dermis. When we talk about superficial chemical peel, we are trying to remove the stratum corneum, which is the upper layer here, and also up to the epidermis layer. When we talk about medium peel, we are playing with the dermal layer also we're going to remove. So when you go to any aesthetic clinic, make sure you ask it first. Don't simply just say that it's a chemical peel. Phenol can go up to it can really remove all the dermal layers. So be careful. But why we want to do this? Why we want to damage your skin? This is what we call a control injury. We hope to achieve that. When we do that, when we remove the so-called bad skin layer, the new skin will grow and you're going to have a better skin or brighter skin. Yeah? And now, energy-based devices. There's a lot out there, and you can see that some of them look like a spacecraft, and so weird looking now. When I started, it's only a few that I know, but now you got 1,001 types. Yeah. So I'm just talking about the technology. This is also to share with everyone, for those who are not in aesthetic field. There's a lot of laser out there, and when we talk about laser, it's not only one type of laser. There's several type of laser. Fractional laser is one of them. You know, either using CO2 laser or erbium yak laser. So how they does, well, this is what we call microthermal zone. Fractional laser is an evolution of ablative or ablation laser or ablative laser. Those days when they don't have any fractional laser technology, what the doctor does is to use laser. You know how laser works. It gonna shoot all over your skin, the uppermost layer of your skin, hence removing everything. It can go as deep as epidermal and dermal layer. Remove everything, the face looks so red and raw, and hoping that new skin will grow from there. That's ablative laser. But now once they come out with fractional laser, that means they are creating a microthermal zone which actually they only burn certain area but leave healthy area in between, hoping that by doing that, the reepithelialization, collagen remodeling got to become faster. The wound healing going to become faster. Yeah. So this is the fractional CO2 laser. And radio frequency, also of course everybody knows radio frequency, such as Thermash, yeah? And also RF micro needling. Yeah? They are using electromagnetic wave between 0.3 to 10 megahertz, generate heat in the dermis, stimulate collagen, you know. And we hope that it promotes neocollagenesis. RF microneedle, I think, is another ingenious invention. What it does, because you know when you talk about radio frequency, you can only heat up to a certain layer, and sometimes it also damages the epidermal layer, even though you want to target the dermal layer. So what it does with microneedle radio frequency, the needle normally is insulated, and only the tip are exposed so that the tip can go up to the intended layer and emit the radio frequency energy, hence only tighten or cause control injury on that particular area. And HIFU is another thing that relatively new in the market, in the industry. So HIFU is high intensity focused ultrasound. There's a lot of brand out there. But what it does also, it uses ultrasound energy. You know, ultrasound for baby scanning, this is diverge sound wave. So it goes that way. So it reflects to the baby, to the bone, it echo back, then translated into an image to your screen in ultrasound machine. But HIFU is where we converge the ultrasound, the energy into one point, so that that point actually can cause wound healing process, can cause controlled injury to that particular area, to some say up to 70 degrees, which we bypass the upper layer. So it is an ingenious invention also. So this can be controlled. The target, actually the first HIFU device historically was invented because they wanted to target the SMAS layer. I think plastic surgeon like Dr. Margaret, Dr. Jeffrey should know better. But their intention at the time to target the SMAS layer, because they believe that when they target the SMAS layer, it will improve. It can cause tightening of the skin, especially on the facial area. Yeah, but they don't stop there. Why don't they say, why don't we can also adjust it into 3 mm, 2 mm, or 1.5 mm to target on a different layer of the skin, also to promote wound healing, and also stimulate fibroblasts to increase production of collagen and elastin. And pigmentation laser also is another option for ladies out there, such as Q-switch, NDX, Pico laser, Pico laser, ladies and gentlemen, something that you need. I think I need to tell this. Pico laser and nano laser. Anyone knows which one is better? What's the difference? Pico and nano. I have a nano laser. Nano laser or pico laser better? Nano, yeah, see, that's a term that they use actually. It's a marketing hype. You know, when pico laser came out, initially it started with nano or Nd:YAG laser. Nd:YAG laser uses pico, nano, femto is just a pulse duration. For those who are in engineering, in physics, they should know this. It's about pulse duration. The shorter it is, they assume that it's better because it breaks, it can cause breakup on the pigment or on the dyschromia. So what it does actually when we use pico or nano, actually we want to make the pulse duration shorter so that we target on the intended chromophore such as the melanin or the dark pigment. So that's what we do. But in all honesty, nano or pico is the same, will have a same result. So it's just that pico is something new. You can also go to any clinic that have Nd:YAG laser. Normally, some of the doctors doesn't even know what pulse duration that they are using in their machine. So they're using a nanosecond. It's still safe. Actually, I can go give lectures on the physics of that, but again, it is, I mean, it's sad for me to see some of our patients, some of the clinics, in fact, or even spa, Medi-Spa, who are claiming that they are better than the other. No, it's about how to assess the patient and how to shoot the laser precisely and to target on the specific chromophore. So for those who are in this industry, Anderson and Parrish selective photothermolysis theory is very important. This is sort of something that you need to memorize and remember, and to enable you to perform a proper laser treatment. Fractional laser and Nd:YAG laser also is different thing, yeah, ladies and gentlemen. So be careful because, you know, some companies will just say that it's okay to use both. So on injectable, so you can opt for that, you know. I know that I'm running out of time. Can I get another 5 minutes? Yeah. Okay, so botulinum toxin. Botox is a brand. Whenever you say Botox, actually you are promoting another company brand, Elegant. So I always say it's toxin, yeah. So how it does, what it does actually, it blocks acetylcholine, yeah, cleaving the snare proteins. That means it stops the function of that small muscle around our eye area. When the muscles stop functioning, that means we cannot make any expression. When we cannot make any expression, what happens? You don't develop any lines. So in order for you to save up on Botox injection, don't make any expression. So have a, you know, what they call it, joke, is it a joker face they call it? Just, you know, don't make any expression. So you can save a lot of Botox injections. So, but nowadays, the development of aesthetic, they noticed that Botox or toxin also inhibits sebaceous gland activities. It inhibits eccrine gland activities, sweat gland activities also. That's why they inject on, you know, on your palm, on your armpit also, because it reduces the sweat gland activities, hence reducing, you know, for those who have hyperhidrosis issues. It decreases vascular dilation, yeah. Microdoses of mesobotox can also improve skin texture and pore sizes by reducing sweat and sebum. And hyaluronic acid fillers, I think this is a common one. We can go and target the wrinkle, you know, all what so-called static wrinkle. You don't make expression, but the wrinkle is still there. So this is, unfortunately, you can't do much, but you probably need to go to any aesthetic clinic to get it done, to get the injection. But this is reversible. During my time, as I said, I used bovine collagen, which is quite it's worrying actually at that time. I got a lot of allergic reaction on my patient. You know, all are okay with bovine collagen. Cockerel comb, I told you that just now, they use that, the process. But now they are using hyaluronic acid fillers made from bacteria. It's safe, don't worry. They have FDA and MDA approval. So what it does, we inject that. They are cross-linked. HA fillers, just an advice or to share with everyone, the audience. HA, they have cross-link, non-cross-link. You ask your doctors what's the difference, if they should be able to know. But if they said, I'm using a non-cross-link fillers, you only going to expect it will last about 4 weeks to 6 weeks the most, non-cross-link. In order for them to last longer, it need to be cross-linked with some products or chemical so that it lasts up to 1 year or 18 months. No fillers can last up to 3 years. That's total nonsense. So please remember, it will degrade. HA fillers is a polysaccharide. So what happened with polysaccharide? Polysaccharide is carbohydrate. It goes to your body. It will, if non-cross-linked, theoretically, it will last between 24 hours to 48 hours actually before it break down into CO2 and water. So, and it degraded by hyalase or hyaluronidase. So it's an enzyme, something new also in aesthetic world, so that if you overfill, you can neutralize that, which is better. Last time, if I were to inject too much on my patient nose, look like Red Indian, so they're going to live with that for the next 12 months probably. I can't do much with that actually. But now it's better. You go underneath the eyes, the back looks so bigger, so you can always improve on that. So injectable, so biostimulator is something new. So mechanism of action. Biostimulator is different from the normal fillers. It stimulates collagen type 1 production. CAHA or calcium hydroxyapatite stimulate collagen type 1 and 3. Polycaprolactone or PCL stimulate collagen synthesis while providing temporary filling effect. This is new, relatively about 4 or 5 years ago, yeah. And also skin booster. The way of doing skin booster injection is like micro bolus injection all over the face. This is where they are using non-cross-link fillers, yeah. So to hydrate, stimulate fibroblastic activities, and encourages collagen and elastin synthesis. And last one, regenerative medicine, or second last one. Regenerative medicine is where this, for example, you can use PRP. This is where they have a lot of growth factors. And I'm saying this, please don't get me wrong. Ministry of Health doesn't approve this. I need to disclose this. I know that some clinics are doing this on their patient. But we know that, all the growth factors will help to stimulate some of the fibroblasts, yeah, induce ECM remodeling, yeah, and regulate cell proliferation, for instance. And exosome also is a new thing now. Everybody's talking about exosome, apart from stem cell. I don't put the slide on stem cell because stem cells, so again, any center or clinic that offer you stem cell therapy, it is illegal. Mark my word. They are not allowed to do that unless it is for research purposes. If anything goes wrong to you, your insurer may not cover your whatever adverse complication that you may have. So stem cell is something new, but I don't want to talk much on that because of that sensitivity, because I know that a lot of big companies are doing that now. Exosome is something new. Exosome is considered as a biological substrate from a human. So it is not considered, it's a dead cell basically. It's not even a cell to begin with. So it's a cargo, it's a messenger. It brings all the, RNA, growth factors, lipids, and etc. to the recipient cell, so that as a delivery or a delivery cargo to that particular cell, so that it enhances dermal integrity, reduce oxidative stress, and suppress the pro-inflammatory cytokines. Exosome also is a big topic now, so it takes some time to understand. And last one is lifestyle and nutrition. So again, this is something that the simplest thing that we can do at home, collagen boosting diet includes protein-rich foods, vitamin C, zinc, omega-3 fatty acid. I think I'm pretty sure a lot of you guys are eating this now, eating healthy. Hydration, ensure optimal skin moisture. Exercise is important. It enhances circulation and supports skin health. Sun protection, of course, use proper sun protection, either oral or topical sun protection. So these are some of my papers that I publish. I think I also share the last one that we published is about prevalence and assessment on and underdiagnosed impact of body dysmorphic disorder. So this is interesting because I can see that more people now, they wanted to do aesthetic treatment, but especially for The aesthetic doctors, I pitied them because we didn't know. We need to realize some of our patients are having a BDD issues which it need to be treated. They need to be treated from a psychiatric or psychologist point of view. Women facial aesthetic preferences among Malaysian also is very interesting. This is where we did a study survey on Malaysian public, Chinese, Indian, and Malay. We want to know what are your best preferences. What you think about, how high is your nose? How high is your brow? So we had that paper. You can check it in Journal of Cosmetic Medicine in international journal. Actually, we publish. This is my books for those who want to buy. My publisher asked me to put this on because buku tak berapa laku. But this one is cheaper. The Naked Truth is something that everybody can buy. Please contact the publisher. Telephone number there. It's only 50 ringgit to make you understand about aesthetic medicine. I think that's all from me. Thank you very much for your kind attention. Thank you.
Thank you very much for the interesting talk. I actually invited him because I needed to know how to rejuvenate my skin. So maybe we can take a few questions from the floor. Anyone? Anyone with question?
Wait, I got one.
Thank you for your excellent talk. I really enjoy very much. For as women, we know rejuvenation is quite our. Whether you are whatever age you like to be, to look young and pretty. Okay, your slides just now mentioned about this chemical peel. Many years ago in my practice, I don't know how you, maybe 20 years ago, I can't remember. We had one time had this skin peel, chemical peel. We call about the guy call it acid peel. Is it not in fashion now? Just like to ask, just for curiosity's sake, because at that time, at my time, the one was that time I think aesthetic medicine has not come into the market so aggressively. That's what, as a GP, part for interest, also part for my business, my income. Thank you.
Thank you, Doctor. Glycolic acid is part of AHA or alpha hydroxy acid group. Yeah, it is still in use now. They have up to 70% and normally use 35%. But there's a lot of evolution after that. Now they have a lot of mixed chemical like jasnapil, phenol or TCA, which they use more common. I mean, just to share with you, Madam Doctor, now there's trend now in public for the younger generation. They use sugar as their pill. Why? Because sugar actually, in theory, is glycolic acid. Because sugar is made from sugar cane, glycolic is actually from sugar cane. So that's why now some of them say, oh, why don't I saw a few social media influencer put sugar, melted sugar, of course, on the face so that they look younger because they contain glycolic acid, that's what you said. Thank you. I hope that answer.
I think I will go back and try. Maybe it make me sweeter. Okay, because of time constraint, we'd like to thank Dr. Unku in a usual way, and then move on to our next speaker. Okay.
All right, we have our next speaker, Dr. Yi Siu Yi, a consultant dermatologist. We bring straight from KPJ Klang Specialist Hospital, and will share about her topic on psoriasis. Right, please welcome Dr. Yi.
Hello, hi. My name is Yuli. All right, okay. Today I'll be talking about psoriasis. So basically, I'm standing in between the lunch. Right. So without further ado, I'll start with this. So before that, we have Dr. Ungu telling about our aesthetic counterpart. So I'll be talking about psoriasis. Right. So something a bit more serious, lah. Right. So with that, all right, okay, outlines for today's talk will be what is psoriasis, right, okay, risk factors and also trigger factors, the pathophysiology, clinical picture, differential diagnosis and diagnosis, assessment tools, comorbidities, management and treatment, myth or facts of psoriasis. Okay, this is prepared because I believe today we also have our other healthcare team, our nurses and also paramedics and also our GPs with us. And the last one, what's new in the horizon for psoriasis? So introduction, right? So psoriasis is a chronic immune-mediated inflammatory disease. So basically, our body's own immune system has become hyperactive, triggering inflammation, which then leads to rapid multiplication of skin cells. Right. So from the picture, right, okay, you can see unaffected skin of the patient and also a psoriasis lesion. Right, this is a histological point. So with that, we need to know what is our prevalence of psoriasis in Malaysia. All right. So a study conducted between 2010 to 2020 in Johor, Malaysia, estimated the annual prevalence rate of psoriasis is approximately 0.34%. Comparatively to US, they have almost 2% of the population suffering psoriasis. So prevalence trend in our country was 0.27% in 2010. It increased to 0.51 in 2020. So the low rate does not mean that we are having lower psoriasis. It's just that probably we have not been able to capture all the patients having psoriasis because our patients come in different walks of life. They go to our GPs, they go to our specialists. So these are the patients that we may not have able to capture in our registry. So in terms of what we have on registry, Indian individuals have the highest prevalence at 0.54%, followed by Chinese 0.38% and Malay at 0.29%. So the prevalence are more in male compared to female. And the common clinical presentation was chronic plaque psoriasis, 85%, gutted psoriasis, 2.9%, erythrodermic psoriasis, 1.7%, and pustular psoriasis is 1%. All right, but this is not the latest data. We are still waiting, all right, okay, for more data to come in. So what are the risk factors for psoriasis? So mainly it's genetics or family history. So HLA-CW6 is the susceptible allele within the psoriasis susceptible 1, all right, okay, which lies in the basically the chromosome of 6p21. All right. Of course, at this moment, as the research goes in our European countries, there are more actually susceptible alleles that is there. All right. So those who actually have HLA-CW6 is associated with the early onset and severe and unstable disease. In a genetically predisposed individuals, various trigger factors can elicit the disease. So these are all the genetic variants, all right, okay, and their location on the chromosome that actually had been discovered. But so far, SOR1 is the main trigger. So prevalence of this HLA-CW6 allele in the general population varies from 14 to 59%. The psoriasis population, the percentage of this patient with this HLA-CW6 varies from 10 to 77%. However, HLA-CW6 in patients with psoriasis is more frequently found in Caucasian patients than our Asian population. So basically, we need more actually studies. So from the HLA, by presence of HLA-CW6, we actually can classify the patient to type 1 psoriasis or type 2 psoriasis. So basically, these are the table, all right, okay, been tabulated. There's type 1, you have onset before 40-year-old. Type 2, you have onset after 40-year-old. Right? Okay. Type 1, you have a diffuse skin disease. Family history are more common. Right? The trigger factors are infection, stress, obese patient. They commonly presented with gutted psoriasis. They tend to have a milder joint disease and also more remissions during pregnancies and better response to methotrexate and ustekinumab. So with that, we go to our trigger factors. All right, so basically they are not the cause. Basically, if we consume alcohol, you're not going to get psoriasis. All right, but if you already are genetically predisposed to psoriasis, all right, and you consume alcohol, all right, okay, the risk of psoriasis actually appearing, all right, okay, becoming a problem is more. So other alcohol consumptions, other factors like obesity, smoking, psychological factors, history of skin disorders. Having the skin disorder within the past a year is a risk factor for psoriasis, infections, Kopner phenomena, and drugs. So this actually is a diagram, all right, okay, that summarizes all the trigger factors and also all the the risk factor. So basically, you can divide. Here you can see it's divided into extrinsic and intrinsic factors. So with that, I move on to pathophysiology of psoriasis. So basically, this is a very simplified version, all right, okay, so that I hope everybody will be on the same page. All right, subsequent slide is more detail, all right, okay. So basically, we have a trigger factors, as mentioned earlier, and a predisposition factors, which is genetics, all right, and then it results in activated immune-mediated inflammation, which result in activity on T cells, colonies, dysregulated immunity, and keratinocyte hyperproliferation. So why is it important? By knowing the pathophysiology, we can actually have more research, tailor-make more our medication to cater for our psoriasis need. So with this, there's a busy diagram beside it, normal for psoriatic, pre-psoriatic skin and also psoriatic skin, where all the inflammatory markers, the cytokines, and all the whatever protein peptide is there. But what we are going to focus on today would be, all right, okay, that what was highlighted. All right, okay. So clearer? We are looking at TNF, IL-17, IL-23. So this is the more complicated version of it. We're going deep into what is the main, cytokines or factor that is going there. So it basically involve both our innate and adaptive immunity. So for this talk, I will actually skip this part, right? For our dear colleague GPs, our nurses, it may be a bit boring to them, right? But the slides will be available to the organizer. You can get it from them, right? So with that, we next on go to what are the presenting signs. So basically, when patient comes to us as doctor, whether are you a GP or are you a general physician or are you a surgeon, what are the common presenting signs? It can be scales, patient complaining a lot of scalings, persistent rash, right? Itch, which accounts about 77% for our Malaysia psoriasis registry, pain, 13.8%, swelling, joint pain, and dandruff. So characteristic of our psoriasis. They are usually symmetrical. From the diagram, you can see there's atopic dermatitis and psoriasis, right? It's usually located at the extensor surfaces. They are actually well demarcated borders, okay, comparative with eczema. You can see the border difference, eczema and psoriasis. Basically, you take a pen, you can draw the border of the line, but eczema, you can't. So they are usually pink to red color in Caucasians, but skin of colors, we don't see pink or red, right? A lot of literatures, even if you go online to Google up how the psoriasis plaque looks like, basically they will show you what is Caucasian's spectrum of disease. So other than that, we also look into the scales, all right, okay, they are plate-like scales that's easily peel off, all right, okay, I found this, the patient, it comes in a whole piece, right? They also bleed easily on scratching. When you move the scales, okay, you actually find pinpoint bleedings. That is what you call the auspice sign. And they also have Kopner phenomena, where linear plaques, it occurs at the site of skin trauma. We do have patients who are our psoriatic patient, after they go through, they have underwent operation, surgical procedures, their psoriasis actually occur at the site of the surgical sites. So what types of cutaneous psoriasis are we looking at? So morphologically, there's plaque, all right, okay, and then there is a guttate, all right, small little ones, all right. There's also inverse psoriasis, whereby it happens over at the flexural area, okay. Atypical, commonly we see on extensors, but we do actually see over at the flexural area. So most of the patient will come to you, doctor, I have this. So first instance, most of the doctors will be like, oh, okay, you have a fungal infection. So despite your treatment, you realize that it doesn't get better, right? So psoriasis should come into mind. So and then we're looking at pustular psoriasis, right? This is a close-up view of the pustule, very superficials, and also erythrodermic psoriasis, right, which covers almost 80% of the whole body surface area. So locations, scalp, commonly 60% for our Malaysia registry. Nails, 57%. Patient will complain of pitted nails. Patient will have onycholysis. They may have nail dystrophy. Genitals, your palmoplantar, alright, okay. And then, of course, your joint and also your facial. Your facial psoriasis is around 28% according to our registry. So, is this psoriasis? Yes, this is also psoriasis. So basically, psoriasis present in multi-morphology. And with these days, our pharmacies booming, is a booming business. So a patient tends to go to a pharmacy to get treated, right? So they may not come to you in a typical form of psoriasis plaque. They may not even have scales, right? They may not even be raised. They may not even have a well-defined borders. This is also psoriasis, right? Acrodermatitis of Halipio, involving all the tips of the nails. So it's dystrophic. It's extremely painful and uncomfortable. Of course, it's not life-threatening, but it's very uncomfortable for patient. So with that, we go to a differential diagnosis. So commonly, plaque psoriasis may be confused with our tinea, okay, or fungal infection, all right, which have elevated borders, slowly extending aging, and also positive in mycology. The other one common one will be of discoid dermatitis, right? You should have more itch, vesicles. They are more dry rather than plate scales. Their scales are usually very fine, all right? Psoriasis, rosacea also, all right, okay? These are the few that's listed commonly we present to the patient, the differentials. So with that, we go to diagnosis. So how do we diagnose psoriasis? So history of the illness, clinical examination, and also investigation. All right. So what investigation do? We do skin swabs for bacteriological to identify secondary infections, throat swabs, skin scrapings, all right, skin biopsy to confirm diagnosis, which we do not commonly routinely do, all right, but we do it sometimes when the patient come in an atypical morphology. Blood counts, electrolytes, calcium, liver function tests, all right, okay, are the battery of investigation. Why do we need to do the blood test? All right, follow through, I'll let you know why. So there are biomarkers in psoriasis. So right now, we're in the era of developing more way of investigating psoriasis, confirmatory in terms of biochemically. All right, so far in the internal research, we have there are biomarkers from the blood, tissue, and genetic transcription. But we are still looking, all right, okay, for a specific biomarkers, like an autoantibody, like how we know about SLEs. We have ANAs to check for if you want to suspect SLE. So now we're looking into that era. So assessment and scoring tools. So I think this is important, all right, okay? Without assessment or scoring tools, you wouldn't know how the patient, is it improving, is it worsening, all right? So these are the common tools that we actually use, right? Which can be done by anyone. It's very simple, actually, tools, all right? Anyone, you can just look it up online, you have the scoring. They even have actually calculators these days, all right, okay, on our phone, all right, okay? Just write it down. So next time when the patient comes to see you, all right, okay, you do the scoring again, so you know, have the treatment we give to the patient, all right, okay, cause improvement, all right. So with that, I go through very simple body surface area rule of 9. I think everyone's very familiar with this, all right. You can also use Palmer methods, all right, which is simple if the whole of the limbs are not actually covered by the psoriasis plaques. Right? It uses a patient's palm. One palm is 1% of the body involved. Right? The other one is PASI score. All right, okay. Most of those dermatologists we use PASI scoring, all right, okay, to help to ascertain our severity, all right, our extent of disease, how the plaque is like, all right, okay. Then with that, we go through the investigator global assessment. Okay, it's very simple. You don't have to have any tools. Okay, you have to look at the patient and then you know, okay, you are scoring 0, 1, 2, 3, or 4. All right. Then the LQI, all right, Dermatology Life Quality Index. So basically, it's scoring to measure our health-related quality of life for adult patient when they're suffering a disease. So we want to know what's the impact of the disease on their routine life, how about their relationship, how about their work, right? So basically there is a scoring, consists of 10 questions, all right, okay, and then we score it, and then we will know what is actually the significance of this disease impact on their life. So what we are looking at, all right, okay, would be this: more than 10 is significant. So we need to take action that's more than 10. So all these scorings are important because it will guide us on what is the next step we should do for our patient, right? So PES, all right, okay, this is a score, all right, okay, psoriasis epidemiological screening tools, all right, okay, we do use, right, what for actually basically to screen for joint involvement or psoriatic arthropathy, right? After we do the screening, we notice that it's actually significant, we will refer to our rheumatologist colleague. Psoriatic arthropathy compared to a rheumatoid arthritis is much more worrisome. Joint destruction or psoriatic arthropathy is as early as within 6 months. And the patient, most of the time, they'll come to you, they'll be thinking, no, maybe I'm old or maybe I'm overworked. So they tend to come to us late because they are still okay, they still can go around the work with it, right? So what does this basic screening consist of? Number one, have you ever had any swollen joint or joints? Has a doctor told you that you have arthritis? Do you have fingernails or toenails that have holes or pits? Have you had pain in your heel? Have you had a finger or a toe that was completely swollen or painful for no apparent reason? So any one of these score yes, more than 3, all right, okay, then you should refer to rheumatologists. So with that, we look into comorbidities. So the studies show that people living with psoriasis disease are at higher risk for following comorbidities. It can be arthropathies, all right, joint involvement, cardiovascular diseases, heart disease, metabolic syndrome, obesity, hypertension, dyslipidemia, type 2 diabetes, and also psychological counterpart, anxiety and depression. Basically, the list is endless, right? But I'll zoom into this burden of psoriasis. People with severe psoriasis, right, where the LQI is actually more than 10, the scoring just now, all right, they are 58% more likely to have a major cardiac event, heart attacks. They are 46% more likely to have a diabetes. They are 44% more likely to have stroke. Right? So that is really pretty significant. It's more than 50%. It's half of the patient who are having this severe psoriasis. So in terms of psychosocial impact of the psoriasis, all right, okay, 89% they reported of shame and embarrassment. All right, there are 62% with depressive symptoms. All right, so basically all are more than 40%, which is very significant. So this is a journal by the American Heart Association. All right, okay, so it's the main basically context of what it's trying to say that psoriasis actually share a common pathway to our coronary heart disease. All right, common pathway of inflammation. So as important as you think our heart is, as important as you think you need to prevent the heart attacks, this is as important as psoriasis, severe psoriasis patient need to receive treatment, appropriate early diagnosis treatment, and also of course management. So in terms of management wise, so first of course, we need to establish a diagnosis, right? Diagnose and the type of psoriasis, the severity, comorbidities that's involved, and also we go to treatment. Management of psoriasis also involve a multidisciplinary approach, right? Involve referrals to dermatologists, rheumatologists, psychiatrists, cardiologists, endocrinologists, dietitian, and basically it's endless, right? Depending on the comorbidity that's involved. Acknowledgement and empowerment and motivation to the patient is very important because this is a long-term disease. For us dermatologists, we tend to see the patient lifelong, right? So, and also in the follow through the treatment progress, right? So when the treatment doesn't work, we have not achieved, all right, okay, the clearance that we are looking at. So we need to change, we need to adjust, we need to calibrate our treatments, right? So factors that involve the treatments are age, type of psoriasis, site and extent of psoriasis involvement, previous treatment received, and other medical conditions like maybe the patient may be pregnant, right? Elderly, people with kidney dialysis on board, right? Okay, so all these factors are taken into account. So we basically tailor-made every single patient. So in terms of pharmacological treatment, okay, broadly we divided into three: local treatment, topical treatment, creams that you usually apply to the patient; phototherapy; systemic treatment, which is divided into non-biologic and also biologic treatment. So topical therapy, we have topical steroids, our quota preparations, Sabita, Pintazole, our topical calcipotriene, the Divobats, all right, okay, your calcineurin inhibitors, your tacrolimus, pimecrolimus, topical retinoids, keratolytic agents, and also moisturizers. I'm not forgetting that. So these are all, okay, is available. Some are over the counter, okay, some is with prescriptions. Right, these are topical treatment. So phototherapy in psoriasis. You know, we are common, right? When we see newborn having jaundice, they put under the lamp, all right, okay, for phototherapy because of the jaundice, right? So in psoriasis, we do also phototherapy for the patient. All right. So the mechanism of the phototherapy in psoriasis, it alters the cytokine profile, all right, okay, from a pro-inflammatory to a less inflammatory state, all right. Induction of apoptosis of the abnormal cells, all right. Promotion of immunosuppressant, all right. The types we have are UVB, narrowband UVB, UVA, PUVA, and IPL. So basically, these are different in terms of their spectrum or the wavelength. So these are actually the wavelength we're looking at, all right, okay. So we are actually, these treatments are actually from our visible light, ultraviolet light spectrum, right? Okay. Our babies, the neonatal jaundice, okay, they are actually when they have a phototherapy for them, right? Okay, the light therapy is on a spectrum of visible light, the blue light, right? These are our photo cabinets. It's like a small little cupboard, okay, filled out with all the lights, lamps. Just go in, all right, okay. It takes around 5 to 10 minutes depending on the patient's skin condition. But it's a bit tedious because patient will need to come back to us every like 2 to 3 days in a week. So it's very time consuming for the patient. So next, we go into non-biological therapy for psoriasis. Right, we have methotrexate, cyclosporine, acitretin, apremilast, and JAK inhibitors. Right, so basically, when you look into each one of it, you realize that wow, you know, it's basically quite a strong medication. Methotrexate, yeah, okay, classically we do use in our chemotherapies, right, okay, for our, you know, various of chemotherapy conditions, right. Cyclosporine are immunosuppressant. We are suppressing the immune system, suppressing the inflammation to prevent hyperproliferation of keratinocytes, right. Acitretin is our oral retinoids, it's vitamin A, right, derivatives. Apremilast is a new one, right, okay. It's not so new in the market in the world, but it's pretty new in Malaysia, all right, okay, and also JAK inhibitors, right. So with this, I think I will go into more detail, like how it actually works, right. So basically, then we move on to a biologic treatment. It's basically we use actually a treatment, a medication derived from a living organism, basically like peptides, to target a specific part of the immune system that's involved in the psoriasis. All right, so it's designed to block the overactive immune response that leads to a rapid skin cell turnover. Right? So basically, what's the difference between biologic therapy and non-biologic? Non-biologic therapy, basically, they just suppress your immune system generally, fully, and completely. Right? Okay? Irrespective of what is the pathway of psoriasis. All right. So biologic is more like a targeted therapy, specific, right, okay, to a specific component, right, okay, which that actually causes inflammation in psoriasis. So here, all right, okay, you can see from the picture, all right, okay, there is actually these are the sites, targets on the psoriasis inflammation. Okay, we have a TNF, anti-TNF, we have IL-12, 13, we have IL-23. All right, okay, we have IL-17, right, okay, so instead of blocking everything, all right, like what does methotrexate does, right, okay, it blocks specific pathway. So with that, the side effect is less, right, okay, comparatively to a conventional, you know, our methotrexate, our non-biological therapy. So these are the least types of biologic therapy available in our markets. All right, okay, there's quite a number of them, but it comes with a quite hefty price. It's safer, easier to use. We are not concerned about like immunosuppressant like our methotrexate and cyclosporins. So how do we approach our psoriasis, right? So I hope our fellow colleague GPs and the primary cares are still here, all right, okay, with us consciously. So psoriasis patients, when they present to primary care, we need to assess them. Of course, one, diagnosis is important, right? Severity and whether there's joint involvement and other comorbidities. So with that, then if there is joint involvement, please refer to our rheumatologist colleague, right, okay, as early as possible, all right? So tell that to the patient, please go immediately. Even our rheumatologist colleague, when they saw a referral letter with the impression throughout psoriatic arthropathy, they will be quite concerned and they will try to see the patient as soon as possible, right? Because joint destruction is irreversible. So then we also see, all right, okay, at the same time, the comorbidities. So if the patient have diabetes, if the patient have, blood pressure or have a depression, then we need to refer to appropriate specialty, right? So from the severity, okay, we divide mainly into the three different groups, right? That's where this now the scoring that I talked about earlier, the tools that we use are important, all right? So there's body surface area or PASI score. So either one, okay, which is convenient to you. So probably my friends who is in the GP line, all right, okay, they are more convenient, they are more confident to do the body surface area. Well, then just go ahead, do body surface area, all right? So body surface area that is actually less than 10% or area of less than 10 palm of the patient, palm size of the patient, right, is mild. Okay, moderate is okay when there is more than 10% to 30%, right? Severe, all right, okay, definitely is more than 30% of surface area. Okay, so with that, all right, okay, we go on to what we should do after we knowing it's psoriasis. After knowing the severity, what are we going to do? So if it's mild, all right, okay, then we go for a topical therapy. Right, but at the same time, you need to assess, all right, okay, the DLQI, Dermatology Life Quality Index, right? It can be 1%, all right, okay, but it can affect the patient life tremendously. Example, it may be on the palms or soles that prevent the patient from walking, which is painful for them, all right? So these are the special areas that actually involve. Right? So if that is the condition, meaning the LQI is more than 10, so refer early, right, okay, to us. All right? So if it's moderate, okay, basically whether it's mild, moderate, or severe, all right, okay, you need to do a DLQI. So body surface area and DLQI, right? So if it's less than 10 and it's mild, you can go for a topical therapy. Okay, so commonly that's available, right, okay, for accessible to everyone, are topical steroids. But at the same time, okay, giving topical steroid, we need to actually remember what type of steroid, okay, we're giving, and also side effects of basically the steroid toxicity. All right. So after giving the treatment, we reassess the patient in 6 weeks' time. Right. So is the patient a responder? How do we know? Okay, whether it's responder or not? So looking back into the scoring tools, all right, okay, has the DLQI improved from 10, it went down to 5, or maybe body surface area from 10, it reduces to 5, or maybe 8%, it reduces to 4, all right, okay. If it's reducing, all right, okay, please continue to follow up the patient and document the severity, ensure it's continually improvement that we are looking at. Okay, at the same time, of course, do not forget the comorbidities, yeah, the diabetes, hypertension, all screening need to be done routinely and also emphasize to the patient on lifestyle modification. So basically, healthy, active lifestyle not only protects your heart from getting heart attack, from stroke, but it also helps with our psoriasis. So if it's moderate, all right, okay, then if the DLQI is 10, all right, okay. So basically, some patients we do come across, the body surface area can be 10, maybe 15%, all right, okay. But they don't feel it's hindering their life. They're still quite okay, all right? So maybe the plaques are in their body where it's covered area, so they don't feel embarrassed. Nobody realize it but themselves. They still go to work every day routinely, all right? So these are people, subset of people. You can try with topical therapy first, see how is the response, right? So similarly, if the response is not good, not great, the improvement is very minimal, all right, okay, then do consider actually referral to us dermatologists. Right? So for those who are severe, that is without say. Either severe in terms of body surface area, okay, which is more than 30%. But right now, we're in the era where quality of life is important. Life is not just matter of sufficient if you're not dying, right? Life is important. It's trouble for the patient to apply creams every day. Imagine a 30% of body surface that is involved, and you just sit down and apply the cream for 1 to 2 hours each session, all right, okay, 2 times a day, would takes up 4 hours in a day, all right, okay. That is not a good quality of life to live, right? So that usually for us, we take more than body surface area 10%. We actually try to get an input, all right? You can refer to us. So more than severe cases, refer to us dermatologists. We also do the same. We also do screening tools. So that is actually our baseline. We will give treatment. Right, okay. Mentioned before, that is either topical or phototherapy or systemic therapy. Right, okay. So that we assess back again to see how is the improvement. So this actually algorithm, you actually can find it in our Malaysian CPG guideline. Right, okay. It's very simple to follow. So treatment wise, all right. So mild, we go for our topical first, all right, okay, moderate or severe, all right, okay, then we will look into whether it's a systemic therapy or a phototherapy, all right, okay. So even if it's severe, we still give a topical therapy for the patient, all right. So these are very busy slides, all right, okay. It's basically on selection of systemic therapy. So basically this is our main what we deal with as dermatologists in our centers, all right? So we, other than knowing the patient have psoriasis, we knowing it's severe, we knowing that the patient's comorbidities is being managed, is being optimized, we too need to tailor make our therapy for the patient. That takes into account of your diabetes, your arthritis, your cardiovascular diseases. So basically these are, what are the first or second lines that we will actually go into. So right now we'll reach the other part of our talk, right, okay, which is myth or facts. So basically I think this part will benefit more to our primary cares, all right, okay, to our nurses, to our paramedics. Sometimes patient comes to you and ask you, all right, they may not ask the doctors, but they may ask you when they're during dispensing or when they're paying, all right. So psoriasis is just dry skin, all right. Is it a myth or is a fact? All right, it's a myth. It's not only dry skin, all right, okay? It's a disease, systemic disease, right? So next question, next statement. Stress causes psoriasis. Is it a myth or fact? It's a myth, all right? The stress triggers the psoriasis, all right, okay? It's a trigger factor, but it's not a risk factor of developing psoriasis. So basically, everyone who having stress, like, oh, I'm stressful for my exams, you're not going to get psoriasis overnight, right? Okay? Yeah, but if the patient already have psoriasis, all right, okay, any stressful event in their life, exams, relationships issues, financial, that actually could trigger and cause psoriasis flare. So next, talking is a treatment of psoriasis. Myth or fact? Myth or facts? Right? Okay, so be surprised, it's a fact. All right? So basically, like you said, psoriasis, a lot of it, is more to like a stress factor. Because psoriasis is a disease that you don't die of it on the spot. It's not a life-threatening condition. All right, okay? So a lot of our psoriasis patients, they tend to keep in their condition, especially those in the area that have in the areas that is actually not visible to the public eye. Right? So they keep it in for many years. They run around to different pharmacies, trying different creams, going to different our primary care teams, or even buying medication from Shopee or Lazada these days. Right? Okay, it's convenient for them. Right? Okay, so sometimes they need someone to talk. They need someone to understand them, that what they are going through that is not normal. All right, okay, what they're going through is not their fault. What they're going through is not curse to them. All right, it's not because of commonly, our Chinese population is that your blood is dirty lah. Need to detox commonly older, generation, they will say it's like this. Right? Then they give you a lot of like taboos thing for you to follow, which is it's not real. Patient need to know they can seek treatment. Okay, there is treatment for it. We're able to control it. So psoriasis is due to hygiene. All right, this is a myth. All right, it's not because you don't shower. It's not because of you don't go for spa. All right, okay, you develop psoriasis. So psoriasis is due to infection. All right, okay, it's also a myth. All right, hot water, sea water, hot spring heals psoriasis. So we do have a lot of patients coming to us, doctor, I go to mandi laut lah. I want to disinfect my psoriasis and make it cure. It's a myth. All right. So environmental factors do trigger our psoriasis, but it is not the cause why the psoriasis actually happens. So psoriasis need culture-related diet restrictions. Oh, ikan tongkol is very poisonous. All right, definitely a myth. All right. So of course, psoriasis, we need a healthy diet. All right. Okay. So what causes psoriasis will also actually, it boils down to your heart attacks, your strokes, your diabetes. Right. So how are you going to counsel your heart patient or your diabetes patient? I hope that is the amount of counseling that we provide to our psoriasis patients too. Next, sun avoidance in psoriasis. Most of our patients, they don't avoid the sun, but just that they are hideous. All right, they can't go out. They're scaling all the time, so they don't. So basically, it's a myth. One of the treatment, phototherapy, that I mentioned earlier, all right, okay, on the UV spectrum. Okay, so basically, sunlight also actually is a spectrum of our wavelength that comes to Earth from the sun. All right, okay, so that is one of the treatment modalities. But it's a specific wavelength. Okay, please don't ask the patient to go and stand under the sun, bake themselves for 30 minutes. Oh, the sun cure you lah. Later you come to dermatologist, doctor, I got skin cancer. All right. Just now, one of the questions from the audience mentioned about Mohs surgery. So basically, Mohs surgery is under dermatology subspecialty. All right, it's done. But in Malaysia, we don't really have a lot of skin cancers like Caucasians. So that's why it's not widely practiced. So our colleague, our plastic surgeons, they do slow Mohs surgery. So alcohol improves psoriasis. All right. Alcohol doesn't mean you need to drink. Some people go and buy herbal medication something that they mix with alcohol, some herbal extracts. All right, okay, it's a myth. All right, of course that includes drinking All right, so if you don't have psoriasis, okay, you're not predisposed to psoriasis, maybe you drink alcohol once in a while. All right, for a social event. But if you do have psoriasis and you're aware of it, drinking it definitely, actually, you're looking for trouble. Okay, the risk of it triggering a flare in psoriasis. Exercise to worsen psoriasis, I'm sure everyone knows, is a myth. Okay, we do encourage exercise, work out for our psoriasis patient. So of course, psoriasis patient will always give us feedback. Doctor, after I exercise, I feel itchy my itchy get worse Right, so there are ways for us to counteract. All right, okay. So sweats. Basically, when you sweat, when you go exercise, go to hiking in the forest, dense forest, all right, okay, these are environmental trigger factor that triggers the psoriasis. All right, okay, so there are ways like you can tell the patient, you can clean yourself after you exercise, all right, okay, rinse, give a good rinse for yourself so that sweat doesn't actually stays on the body surface area, right? So psoriasis affects the fertility. It's a myth, all right? So for those of population, okay, especially young females in reproductive age group, right, okay, so when you do find them with psoriasis, try to refer to them early, all right, okay, because we dermatologists prepare the next phase of life for them, right? So what if they have psoriasis, but it's all right, but when they get pregnant, the psoriasis flare. So we do see such patient, and we need to think what we need to do for the patient, because mostly treatment for psoriasis that is actually accessible to us are methotrexate, cyclosporine, right, acitretin, which is a no-no, especially in a pregnancy. All right? Yeah, so those who are reproductive age, female, young, okay, when they have psoriasis disturbing them, okay, please do refer to us. So we can prepare the next phase of life for them. Right? So there are treatments that we will actually adjust. Yeah? So this is an unmet need in terms of psoriasis, knowledge for everyone, early diagnosis and early treatment. The cost and accessibility of the treatment, right, okay, is also a factor. Nail psoriasis is something that is very difficult to manage. Right? We need to personalize medicine to mitigate our treatment failures. Right? Okay? These treatment failures, the treatment, okay, not only topical treatment, phototherapy, or systemic, even biologics treatment, right, okay, you do encounter failures, all right? And also, of course, adverse events, okay, during systemic therapies, like when you use methotrexate, it's immunosuppressant. People at higher risk of developing our infections. Patient may have side effects like our, like transaminitis, right, okay, your kidney, okay, when you're on cyclosporine. So there's a lot of things we dermatologists does, right, okay, yeah, when we need to start treatment. Before treatment, we need to screen the patient. During treatment, we need to screen the patient, right, after which, does it reach what is our, target? Does the patient improve, okay? When the patient improve, sometimes the patient have unrealistic expectation, similar to the aesthetic field. We do have patients sometimes from 10%, it improved to maybe like 3%. But then they wanted to look for cure. They want it to be off 100%. Is it possible? So that is a question for all of us. All right. So of course all of us are looking for cure, but as if now, right now, right, okay, psoriasis is a disease that we can control, right, okay, but not cure yet. Right? So we hope further research. So then what's new in our horizon? All right, okay. So there is a new medication, okay. Conventionally, we use topical steroids, our calcineurin inhibitors, okay. So tapinarof actually is approved by FDA. 2022 is a steroid-free, it's non-steroidal, so we're not worried about the side effects, but I don't think it's in Malaysia yet. Okay, we're a bit delayed in getting this medication. Next is actually we have also one coming in, all right, okay, the rofamilast, okay, form type, all right, okay. Then the next one, all right, okay, we like biologics, but this is better. Why? Is oral. So basically our biologic medication, the slide I listed earlier, the 15 types of biologics we have, the targeted therapy, they all come in injection form. Okay, some even come in infusion form, whereby you need to admit the patient. All right, okay, let the patient sit in the ward for like 4 hours while waiting for the medication to go into their body. Right, okay. So this the new one. All right, okay. Yeah, it's a new oral peptide. Okay, it's in the biologic category. Right, it's oral. Yeah, so you don't have to come for injection, which is much more convenient for the patient. So with that, all right, okay, there's a take-home message. 1, psoriasis is a chronic immune-mediated inflammatory disease. 2, psoriasis is a systemic disease, okay, have significant comorbidities that result in morbidities and mortality. So we need to manage psoriasis with comorbidities and do a routine metabolic screening for patients. And refer severe psoriasis or suspected psoriatic arthropathy early to the respective specialty. Psoriasis is not just skin disease, all right? So referral. Dermatologists, when it's severe disease or poor response to treatment, okay, some of you may have tried giving topical steroid, you notice, I do at body BSA, body surface area, it's not improving. Or maybe you're unsure of diagnosis, patient have went around shopping for creams and they apply everything or herbal traditional medication, then you say, got skill or not? the border is defined or not? If not sure, so you can refer to us. We welcome the referrals, okay? Because what we do now actually brings a significant change in the patient, not in quality of life, and also life itself, right? And also rheumatologists when you suspect of joint involvement, right? The skin health, last not least, okay? The skin health is as important as our heart's health, all right? So heart and the skin. So with that, thank you.
All right, thank you so much, Dr. Yi Siu Ling.
Do we have time for some Q&As? Anyone, maybe from the floor?
Any questions for Dr. Yi?
Any questions at all? Do we have any questions there?
On WhatsApp. Azri, WhatsApp.
Okay, due to the constraint of time, maybe we can start with, okay, is that...
Dr. Yi, very interesting talk. Dr. Yi,
Yeah.
the psoriasis one, you are saying about the cytokines that are involved. From what I see is that previously it was those using anti-TNF alpha. But right now we have changed over to the IL-17. Is it because now they have discovered that that is the newer cytokine that is being involved that plays a major role? Or is it because it's just that the TNF, anti-TNF is not really working anymore?
Okay, so basically TNF, it does work, all right, okay, but as along, when the research comes, we do realize that IL-17/23 actually provide a much more targeted, specific, all right, okay, treatment for the patient without, meaning is we're delivering a drugs with less side effects compared to TNF. All right. So for us dermatologists, one of the reasons why we are moving away from TNF is because one, we have option, which is more targeted. All right. Second thing is TNF comes with other sets of problems, like your tuberculosis reactivation. Right. But it is still being used by our rheumatologist colleague. It is still efficient. It helps with our psoriatic arthropathy very well. Just that for dermatology, we do have other alternative. So it's better off for the patient.
Okay. I think we will close the session with in the usual style. Thank you very much, Dr. Yi. And then we will go on with our lunch symposium. But before the lunch symposium, I think we will do the Yisang Tosing, Losang, but I don't know the words for it. Sorry. Oh, I think, I don't know. Let she decide.
She take my floor already. All right. So, all right. So before our last speaker for the day, Dr. Sharifah is here now. So can we gather for lunch, or you want to do losang? Lunch first. Can we do lunch first and losang later? Yes. Okay. Yes, I see some northern face. Okay. Please, guys, please queue and have a lunch. We do our last topic later.
Good afternoon, everyone. So I hope everyone has enjoyed their lunch. So this is the last talk for today. Mastering eczema care from diagnosis to treatment success. So this lunch symposium is sponsored by Galderma. So just to go through some terminology. So eczema means boiling over. It's from Latin word. And dermatitis is inflammation of the skin. So eczema and dermatitis is actually the same thing. So these terms are interchangeable. So clinical features of eczema. So different types have their own distinguishing marks. But if it does not itch, it is probably not eczema. So general features include absence of sharp margin, as opposed to the well-demarcated area like what Dr. E mentioned just now for psoriasis. And if it's in acute state, you can have vesicles, bullae, edematous papules on pink plaques. So all types of eczema can have the acute type where they are in exacerbation. So during acute eczema, you will see weeping and crusting, blistering, redness, papules and swelling, usually still with an ill-defined border, and some minimal scaling. If it is chronic eczema, it is more scaly. It can be pigmented and thickened and lichenified. So this is the accentuation of the skin markings or the skin lines. Sometimes the skin is too thick, they are not pliable, so they fissure easily. So this is a working classification for eczema. You have exogenous eczema and endogenous eczema. So exogenous eczema means the triggering factor is actually from the outside. So you can have irritant contact dermatitis, allergic contact dermatitis, photodermatitis, whereby it's caused by sun, phytodermatitis caused by plants chemicals, and a combination of plant and sun exposures causing phytophotodermatitis. For endogenous eczema, you have the most common one, which is the atopic eczema or atopic dermatitis, seborrheic dermatitis, discoid eczema, pompholyx, Stacey's eczema, hand and feet eczema, nodular prurigo, lichen simplex chronicus, asteatotic eczema, which is common in elderlies, and also juvenile plantar dermatosis in children. So we are going to focus today on atopic dermatitis. So how to diagnose atopic dermatitis is clinical. So you must have an itchy condition, skin in the last 12 months, plus 3 or more of the followings, which is itchiness in the creases or flexures, or the cheeks if the patient is under 4-year-old, history of asthma or hay fever, or history of atopic disease in first-degree relative in children under 4-year-old, general dry skin in the last 1 year, visible flexural eczema, or eczema affecting the cheeks or forehead and outer limbs in under 4-year-old, and also onset in the first 2 years of life. So this is the criteria under the United Kingdom Working Party's criteria for diagnosis of atopic dermatitis. So what is the true burden of atopic dermatitis? So it's quite common, can happen in 1 in 5 children and 1 in 10 adults. The major symptom is actually the unbearable itch. 86% of children and 84% of adults reported interrupted sleep. It can affect attendance at work, performance at work, sick leave, and also potentially their job choice. 26% of carers reported that their child has been absent from school 1 to 2 days per month. So this is quite significant. 42% of carers of children and even the 49% of adults themselves reported cutting back on household expenditure because of the cost of managing the atopic dermatitis. 43% of adults has depression, and lots of them also avoid exercise because sweating can exacerbate eczema. So all in all, it can negatively impact their quality of life for the patient and also for their families. So how does it look like? So it changes in their clinical features according to their age. So atopic dermatitis in infancy, they are usually vesicular and weepy. Starts on the face, usually spares the napkin area. If it involves the napkin area, maybe more towards irritant contact dermatitis or seborrheic dermatitis. And also they may have non-specific distribution elsewhere. In childhood, the skin is more leathery, dry and excoriated because of the itching. They involve flexures of the elbows and the knees, and also the wrists and the ankles. Other typical sites include the forehead and the flexure of the neck because of the sweating at these areas. In adults, the clinical features are similar to childhood. By this time, the eczema is chronic, so there is marked lichenification. They have more widespread skin lesions, but low-grade involvement of the trunk, face, and hands. With atopic dermatitis, usually 70% will go into remission by the time they enter adolescent years. But of course, there are also subset which progress all the way towards adulthood. So what is the pathophysiology of atopic dermatitis? So there are multiple interacting factors which contribute to the pathophysiology of atopic dermatitis, and they interact with each other. So basically there are genetic defects causing skin barrier dysfunction and immune dysregulation. And also there is a microbiome dysbiosis. So all this also would start an itch-scratch cycle in patient, which propagate and lead to the chronicity of the eczema. So what is the exact cause of eczema, atopic dermatitis? It's actually unknown, and of course there is no known cure. So even if they get better when they enter adolescent years, doesn't mean the eczema is cured. We call them, they go under remission. So it is a combination of genetic factor and also environmental factors. So by means of genetics, so genetically, the skin barrier, there are defects which disrupt the brick and wall network of the skin. So this one I will go through a bit later, but there are known environmental triggers to eczema, such as extreme cold weather, cosmetic ingredients which contain irritants, fragrances, emotional distress. So you do find that people with eczema have flare when they are having physical stress or even mental stress. Soap and detergent irritants, known usually for this one is the SLS, the sodium lauryl sulfate. Temperature changes from extreme temperatures. Clothing, so clothing which has a woolen structure, so they are rough fabric will cause friction to the skin and exacerbate eczema. Sun exposure and sweating. So eczema flare-ups can be triggered by these environmental factors. So it's a combination of genetics and environmental factors which lead to the development of eczema. So what is atopic march? Atopy or atopic by definition is the genetic tendency to develop allergic diseases. So this includes food allergy, allergic rhinitis, asthma, and atopic dermatitis. So when our body is exposed to environmental allergens, our immune system can go into allergic or tolerant pathways. So in people with atopic tendency, their immune system will go towards the allergic pathways. So they will start with dry skin, which begins at birth, and then eczema or atopic dermatitis within first few weeks or months of life, food allergies within the first few months or years of life, rhinitis or nasal allergies after the age of 3, and asthma in the first few months to years of life. Okay, so family history. So prevalence in children with one affected parent is 60%, and this rises to nearly 80% for children with 2 affected parents. And food allergy, the most common food allergens in children are egg, soy, milk, peanut, fish, shellfish, and wheat, which altogether account for 90% of food-induced cases of atopic dermatitis in a double-blind placebo-controlled food challenges. But if you've noticed here, it says in children, because as you grow older, patients actually develop tolerance to all this food, apart from peanut. So food allergy is not the main triggering factor for eczema in adult. Usually it's in the children below the age of 4. Microbial agents, so Staph aureus, Pityrosporums, yeast, Candida organisms, and Trichophyton dermatophytes can act in 2 different ways to trigger flares. So they directly invade the skin, creating local injury and inflammation, and they also induce a systemic allergic response to specific antigens, causing a rise in serum IgE and enhanced activity of the immune system. So what we can see here is that skin in atopic dermatitis, there is an imbalance of the microbial organism there. There's a reduced diversity. So this manifested as a decrease in the Cutibacterium, Streptococcus, Acinetobacter, Corynebacterium, and Prevotella, and a marked increase in the Staph aureus, Staphylococcus aureus, which is a pathogenic microbe. The other one is environmental allergens, so contact irritants like laundry, detergents, soaps, solvents, woolen clothing, as I mentioned just now, can cause irritation. Preservatives also can cause triggering factors for contact dermatitis, which lead to worsening of eczema. Climate, sweating, and aeroallergens, most commonly house dust mite, but could also include mold pollen, and these all can trigger exacerbations. Genetically, development of atopic dermatitis can happen in patients with loss of function mutations in the gene that encodes epidermal structural protein called filaggrin. So up to 50% of children with moderate to severe atopic dermatitis have a gene mutation in filaggrin. So this mutation will increase transepidermal water loss even before atopic dermatitis develops. And this mutation in this gene represent the strongest and most consistent known genetic risk factor for atopic dermatitis. There probably are other genes which have not been discovered yet, but this is the main one. So even with the normal filaggrin gene, filaggrin levels can still be dysregulated by inflammation. So mutations in filaggrin are associated with a more severe disease phenotype, earlier onset of disease, increased levels of systemic allergen sensitivity, and higher proportion of patients who eventually develop asthma. So they go on to through the atopic march. So filaggrin is a protein that plays two key roles in the stratum corneum. So it contributes to the structure of the stratum corneum, where it binds with the fibrous protein, keratin, and arranges it into filaments. So deficiency causes significant defect in the epidermal barrier and allowing enhanced allergen absorption through the skin, resulting in higher incidence of dermatitis. The other way is it breaks down into building blocks called amino acids, which go on to form this NMF, which is a natural moisturizing factors, and these hold water in the skin and maintain barrier function. So if you have lack of NMF, it leads to dry and flaky skin, which are common features of atopic dermatitis. The other thing that is lacking in patient with eczema is ceramides. So ceramides are integral to the intracellular lipids. So intracellular lipids contain ceramide, cholesterol, and free fatty acids, which work together to protect against water loss and penetration of irritants. And out of all these three, ceramides make up about 50% of all the intracellular lipids, and they are important for increasing water retention in the stratum corneum, and reduced ceramides levels are associated with atopic dermatitis. So if you look at this brick and mortar diagram, so if you look at the brick is actually the corneocyte. So the natural moisturizing factor is within the corneocytes, and the intercellular lipids is between the corneocytes. So natural moisturizing factors, filaggrin, is inside the corneocyte, whereas the ceramide is actually in the lipid bilayers. So in intact skin barrier, you have good NMF, which is a humectant. So they actually hold water inside the corneocyte. And you also have a good lipid bilayer. So they are holding the corneocytes together, acting as a good barrier to allergens, pollutants, bacteria, and viruses. So these triggering factors cannot go through the skin. Whereas in damaged skin barriers, you get allergens, pollutants, bacteria, viruses going into the skin because the barrier is broken. And you also have increased transepidermal water loss, leading to dry skin. So this leads to the itch-scratch cycle in atopic eczema. So they have deficiencies in the natural moisturizing factors and the ceramides, and impact skin barrier. So in turn, the damaged skin allows penetration of irritants, which cause inflammation, itching, and further scratching. And this all leads to the itch-scratch cycle that must be stopped so that the eczema does not get worse. So in patients with eczema, the pruritus is often referred to as spreading itch, and itching is actually responsible for the disease burden for patients and their families, because some of them has never had even a peaceful night of sleep because of the pruritus. And again, apart from the scratching, which introduces all these allergens and irritants, it also stimulates the systemic immune abnormalities, which is the Th2 pathways, and lead to other allergic diseases such as asthma and other allergies. Okay, what is the treatment algorithm in eczema? So as you can see here, the baseline, the basic therapy would always need to include emollients, avoidance of allergies, and also the educational programs. I won't go through all the mild, moderate, severe eczema, but because the focus today is on moisturizers. So as you can see here, even if you have no active looking skin lesions, you still have to maintain your skincare with a good moisturizer. So composition of emollients, it must be fragrance free, because in allergic contact dermatitis, fragrance is the topmost allergen that cause the allergic contact dermatitis, and it has to preferably compose of physiological lipids like ceramides. Rationale for emollients is that it restores the integrity of the skin barrier, counteract the xerosis, and reduce itching. So this is in our guideline. So as you can see here, there's a written eczema action plan. So green means the eczema is under control. See here, we never put it cure, because it's under control even if you don't see anything on the skin. So you still have to moisturize the body after 10 minutes of bathing, and then a minimum is 3 times a day. So basically we tend to usually we bathe twice a day. So after each bathing, and straight away after that within 3 minutes, and then after that one more time before bed. So as the eczema worsen, of course you need to use your treatment cream like your topical corticosteroid or calcineurin inhibitors, and if it doesn't get better within 5 to 7 days, then of course you need to see your treating doctor. So topical corticosteroid should always be used concomitantly with emollients. So how much emollient to use? We still use the fingertip unit. So if you see from your distal MCP joint to the tip of the finger, that much can actually cover 2 palm size of the skin. Okay, and then the choice of the topical corticosteroid and the topical calcineurin inhibitors, of course, is decided by your doctor. But the emollient itself, actually nowadays we say is emollient plus. So they have extra ingredients nowadays with ceramides, filagreen. So all this actually can reduce your usage of topical corticosteroids. But the key here is you have to be consistent and you have to be compliant. So you have to use it at least 3 times a day. So what is the best moisturizer? For each patient is different. Best moisturizer is the one that patient likes the most. So some people prefer cream, some people prefer lotion, some prefer ointment. So they have to maintain this regime for lifelong. So make sure they can find something that they like, and in the end they must choose something that is fragrance free, and also preferably something that has extra ingredients that can do the work of corticosteroid as well. So this is also echoed by the European guideline. So they also recommend gentle cleansing, and then recommend the use of emollients as background to prevent flares and reduce the symptoms of AE. And apart from the maintaining the hydration, applying the moisturizer also has a good way to maintain a good microbial diversity of the skin. Although we can use topical and systemic antibiotics to eradicate this pathogenic bacteria, but of course this comes with the risk of resistance. Okay, so we go on to the science behind the Cetaphil Pro Edederma. So this is the pathogenesis of eczema. So you have the alteration of the skin barrier function, increase of transepidermal water loss, penetration of allergens and pathogens in the skin, activation of a Th2 type inflammatory response, and colonization by the Staph aureus. So the Pro Edederma actually can address all these issues. It has a new formula containing 3 active ingredients, which is the filagreen technology, the ceramides, and the adresil. So filaggrin technology replaces the natural moisturizing factor missing in the skin of patients with AD. As I mentioned just now, 50% of them have genetic mutation in the filaggrin gene, so they themselves don't produce the filaggrin. So by putting moisturizer that has this filaggrin technology, you can help maintaining the good balance. So it restores the skin hydration, protect against the environmental allergens, and prevent adherence of bacteria. And the filaggrin technology in the Pro AD contains the sodium pyrrolidone carboxylic acid, which is the most abundant component of natural moisturizing factor, and arginine, which is also an essential amino acid in the filaggrin. So as you can see here, once you apply the patients with atopic dermatitis, they actually don't have the filaggrin granules. So when you apply the filaggrin, then they can get the granules back, and then a normal skin barrier. And the other thing that is lacking in patients with atopic dermatitis is ceramide. So it is the component of the outermost layer of the skin, limit loss of water retention. And patients with AD has lack of ceramides, especially the ceramides 1 and 3. So moisturizers containing ceramide or ceramide precursor have been shown to improve skin barrier function in the skin of patients with AD. So as you can see here, if you apply the skin identical ceramide, there's a reformation of the stratum corneum lipid bilayer structure. But if you apply the non-skin identical ceramide, this does not happen. So a skin identical ceramide is important. So what is the third ingredient? Ingredient is the adresil. So it improves the altered epidermal differentiation and barrier function. So loricrin is a component of the corneocyte envelope. So it sensitizes is increased by 20%, 21% by topical application of this adresil. And also filaggrin synthesis, as I mentioned just now, very important in the skin barrier, is also increased by 250% with the topical application of this adresil. And again, the two major cytokines of AD, the TSLP, which is which has a direct effect on the neurons, causing itchiness, and IL-8, which is a pro-inflammatory cytokine, they are also reduced when you apply the adresil. And the other component of microbial dysbiosis, which is the increased Staph aureus in the skin of AD, is also it's also been shown that AD adresil reduce adhesion of the pathogenic Staph aureus and promote adhesion of the commensal Staph epidermidis. And again, it also reduces the transepidermal water loss due to the SLS irritation. So SLS is sodium lauryl sulfate. In terms of skin irritants, this is a known skin irritant that causes that produces bubbles in lots of skin products. So that's why in lots of skin care for eczema, they don't have bubbles because they don't use this SLS. So because it causes irritation, and the application of the Pro AD actually reduces this transepidermal water loss. Again, itching is also improved after 7 days of twice daily application on the face and the body. And also the easy score, higher score means more severe the eczema is, also reduced after 7 days and sustained up to 28 days with the twice daily application of the Cetaphil Pro AD. And you can see here the skin roughness and dryness is also improved. And again, on the face, you can also see the redness and itching is also reduced after 7 days. And this actually you can find the symptomatic relief even immediately within 15 minutes, and it continues to improve by day 5 and beyond. Okay, so as I mentioned just now, so for the alteration of the skin barrier function, you have the adresil, the filagreen technology, and the ceramides. And for the increase of transepidermal water loss and the reduction in the penetration of allergens and pathogens in the skin, this can be helped by application of similar things. And also the adresil can reduce the activation of Th2 type inflammatory response and reduce the colonization of the Staph aureus. Okay, so it has been tested in 4 countries, over 340 subjects. And also is part of the CTMP, which is a cleanse, treat, and moisturize, protect, which is a holistic skincare routine. So usually doctors only do the T part. The cleanse, moisturize, and protect is actually for the patients to choose. So this is a paper by 10 dermatologists. They come up with consensus for the CTMP. So for C, you must cleanse with a non-irritating, non-allergenic, non-comedogenic, fragrance-free, alcohol-free, mildly acidic pH, because our skin is, the stratum corneum pH is 5.5. This will maintain and improve skin barrier function. And treat is based on your dermatologist's advice. And moisturize, you need it to restore and strengthen the skin barrier, improve your hydration, improve local tolerance to topical treatment. So this is what happened also in some acne treatments. You know, sometimes they are too irritating, but when you use it with moisturizer, you will tolerate it. Hypoallergenic, bear in mind there's nothing in the world which is non-allergenic. We can only say hypoallergenic. So if it's eczema skincare, they will use preservatives, which is necessary for all skincares. But these preservatives won't be the ones that causes most of the allergic contact dermatitis. And of course, fragrance is not needed. It's not an important ingredient, so it must be fragrance-free. And protect is usually with a sunblock, okay, which can covers both your UVA and UVB. Okay, so I wash with your Cetaphil Pro AD Derma Skin Body Wash. So it's creamy, contains glycerin, niacinamide, vitamin E, sunflower seed, shea butter, arginine, allantoin. So it's drying. And then treat with your treatment cream, TCI or TCS. And then moisturize with the Pro AD Derma Repair Cream or the Pro AD Derma Restoring Moisturizer, and protect with a sunblock. Okay, I think this one the same. So this will help to break the itch scratch cycle of eczema. And it's the main thing with the Pro AD repair cream is that it has the colloidal oatmeal, which also soothe the irritated skin. Okay, instant itch relief is just one use because it contains filagreen, complete skin barrier repair. It has the adresil and the ceramide, which is also lacking in skin with eczema, and can give overnight relief for patient. Okay, accelerates repair within 24 hours. Okay, so these are the products. So cleanse, moisturize, and protect. Okay, any question?
All right, thank you so much, Dr. Sharifah. Can we take 1 or 2 questions?
Yeah, sure.
Do you have any on the floor? Our last speaker for today. Do you have any questions? I got one at the back. Please run.
Hi, just now you mentioned antiseptic bath. May I know which one would you recommend for a pediatric population?
Actually, for antiseptic bath, I don't really recommend like chlorhexidine or bleach bath, because sometimes when you dilute it, it may be too strong. So I think if you use something which can already address the Staph aureus adherence, like the Pro AD one, that's good enough. But chlorhexidine bath can be used, but I won't recommend it for more than 1 week.
Okay, we will only take questions from the floor because we are running out of time. Anyone else? Can I ask a question? I have both eczema and urticaria before, but why is it that the antihistamine doesn't stop the itch from eczema, but it does stop the itch from urticaria?
Because the itch from eczema can be due to the pruritogen, the TSLP. So whereas the itch in urticaria is mainly due to the histamine relief from the mast cell. So that's why the antihistamine can work for that one.
I see. Okay. Any other question? Okay. One
We
more
got one
question.
at the back.
Okay.
How to treat weeping eczema? Do we make it dry first, stop the moisturizer first, let it dry for a few days, and then after that we use moisturizer?
Yeah, actually, with eczema, if it's dry, if it's weepy, you can dry it first. So you can use agents like, normal saline or potassium permanganate. But weepiness can be a marker for infection. So you'd have to give them, assess them for necessities for antibiotics. So that would also help with the weeping. Yeah, you can stop the eczema, the moisturizer at the only at that area, but skin is a very big organ, so the rest of the areas you should still apply the moisturizer.
Okay, we got one here.
Sorry, thank you for your talk. I really enjoyed today's function very well. Just now, I don't know whether I missed anything, because those days we are trained, weeping dermatitis, we can use potassium permanganate. But I didn't see you mention in the one. You said that means outdated, it's not useful anymore, because has been using things like ceramide all these years, and now plus all kinds of
Actually,
or
I still
cream.
use potassium permanganate. Actually, it's
So
a
is
good
it still-
agent. Yeah, it's a matter of diluting it properly.
Yeah.
Because nowadays, I think the nurses also are not familiar. They tend to dilute it, too strong. So the way I do it is like, if you dilute the potassium permanganate, when you drop a coin in it, you should know that coin is how much. Is it 20 cents, 50 cents? So if you do that, and that means the dilution is enough. Sometimes if it's too dilute, it doesn't work. If it's too concentrated, it will cause irritation. But I do use potassium permanganate still. It's a good agent. It's astringent, it's, antibacterial, antifungal, it reduces swelling.
It's a very cheap medicine. Is it still available?
It's
I
available
think
in
still,
some way.
But seems no reinfection to using it
But
now.
it's difficult to find outside. I know, because my patient has tried to find it in
You have
pharmacy.
said buy the crystal, but
yeah.
can you get it loose or what outside? I'm not sure. I've not seen many the GP clinics. Some they don't keep anymore, because those days when during my practice, we used to dilute the bottles and keep the dilute, and patient go back to dilute further. Sorry, that's just to share. Sorry, thank you.
We still use it actually.
Oh, it's interesting to know that whatever you practice now is still being used now. So I pass the mic back to Shi. I think we close the Q&A, and then we go ahead with the program.
All right, thank you so much, Dr. Sharifah, our final speaker for today. So again, without further ado, we are now come to a low sang tossing. So I see some of you sang in front of your in on the table. So before we proceed with lucky draw session, can you guys please put the seasoning, open the low sang, feel free. Yes, please help yourself. We're gonna do a low sang. Anyone volunteer want to do the blessing? Anyone volunteer want to do the blessing? Yes, please help yourself. We have one table here for our consultant. All All right, for our virtual participant, I think this is the end of our session now. So we are here physically. We are doing the Losang ceremony. Oh, wait. Last lucky draw.
No, the online, they have to fill in for the insert.
So for the online participant, there's a QR code that you guys need to scan and fill in for the e-cert. So please do scan and fill in the e-cert. Thank you so much for joining us for the online participant. Once you fill in the QR code, then you may leave the chat room, yeah?